All right. Good morning, Labor, Health, and Social Services Committee. Welcome to day 2 of our third meeting of 2023. We do have a full agenda this morning. 2 bills up before us, generally dealing with similar topics. What I'll call white bagging and prior authorization. We will discuss the prior authorization bill first. That's 24 LSO 68, working draft 7. So for those of you newer to the legislative process, 7 different revisions of this bill thus far, and some lively comment today. Unless anybody has any opening announcements, we'll just kick right in. Ms. Johnson, if you would walk us through LSO draft 68 on prior auth.
Thank you, Mr. Chairman, members of the committee. Anna Johnson, LSO. This draft is 24 LSO 68 prior authorization regulations. There's a staff comment on page 2 informing the committee that the Centers of Medicare and Medicaid Services is in the process of creating a new rule regarding prior authorization that will go into effect on January 1st, 2026. There are also legislative findings that begin on the bottom of page 2 and a definition section that starts in the middle of page 3. 2655-104 on page 8 requires health insurers to make any current prior authorization requirements and restrictions easily accessible on its website. They also have to furnish all requirements within 24 hours if requested, and they shall not implement new or amended prior authorization requirements unless their website is also updated to reflect the new requirements. And they must provide healthcare providers written notice of new requirements not less than 60 days before they're implemented. This statute would also require the Department of Insurance to make rules regarding health insurers, making statistics available regarding prior authorizations, such as the medication or diagnostic test or procedure requested, reasons for adverse determinations, and whether those determinations were appealed. And that information shall also be supplied to the public. 2655-105 describes persons qualified to make adverse determinations, and then 2655-106 requires that health insurers inform healthcare providers if they're preparing to deny a prior authorization request and allow the healthcare provider to discuss medical necessity with the person responsible for determining authorization of the service. 2655-107 provides requirements applicable to persons reviewing adverse determination appeals. And then 2655-108 on page 15 requires health insurers to advise healthcare providers of an authorization or adverse determination within 5 business days of receiving the prior authorization request if the request is non-urgent. On page 16, if the prior authorization request is urgent, the health insurer shall notify the healthcare provider of the authorization or adverse determination not later than 24 hours after receiving all necessary information to complete the review. 2655-110 indicates that no prior authorization will be required for medications for opioid use disorder. And 2655-111 on page 17 indicates that an authorization will be valid for 1 year from the date that the healthcare provider receives authorization. A health insurer shall not revoke or limit a previously approved authorization if the healthcare services are provided within 45 business days from the date the healthcare provider received the authorization approval. And the staff comment on page 18 indicates that some of the language in the model draft was deleted because it conflicted with other statutes in Title 26, Chapter 40. If prior authorization is required for treatment of a chronic or long-term care condition, the authorization shall remain valid for 1 year. 2655-112 regards continuity of care for enrollees. If a person switches health insurers, a prior authorization for a medical service shall remain valid with the new insurer for 90 days if the healthcare service is a covered benefit under the new health insurance plan. During that time period, the new health insurer may perform its own review to grant a new authorization. 2655-113, starting on page 21, regards provider exemptions from prior authorization requirements. A healthcare provider shall be granted an exemption from completing a prior authorization request if in the most recent 12-month period, the health insurer has authorized not less than 80% of the prior authorization requests submitted by the healthcare provider, and the healthcare provider has made a prior authorization request for that procedure not less than 5 times in the previous 12 months. The staff comment on page 21 indicates that the language would have authorized was removed from the draft because the phrase is vague and confusing. And the staff comment on page 22 indicates that enrollees, just cautioning the committee that enrollees may seek out doctors that they know are receiving exemptions for certain procedures so that they do not have to go through the prior authorization process. A health insurer may review whether a healthcare provider continues to qualify for the exemption once every 12 months. And a healthcare provider may appeal a health insurer's decision not to provide the exemption. The health insurer may revoke an exemption if it makes a determination that the healthcare provider would not have met the 80% approval threshold, provides the healthcare provider with the information it relied on to make the determination, and provides the healthcare provider with information on how to appeal the decision. The staff comment on page 26 indicates that the severability section of the bill draft was removed because severability is already covered in statute. And then 2655-114 is a new section that was added since the last meeting. It indicates that a health insurer shall not require prior authorization for rehabilitative or habilitative services for the first 12 visits for each new episode of care. Section 2 indicates that the Department of Insurance has rulemaking authority, and Section 3 provides for a split effective date. And I would stand for any questions.
Committee questions? Not seeing any at this time, so we'll just jump right in. Maybe a little bit off script today because I know a lot of you are familiar with this issue, but you're all with organizations. Is there any just member of the public who's here to talk about prior authorization who would like to go first? I know we have CEO Mincy from the Saratoga Hospital here. I'll probably call him up to go first, just because I know you have a hospital to run. But if there's any other public comment, okay, if you would come on down, Mr. Mincy. Trying to be certainly respectful of your time. Most everybody else is kind of being paid to be here, and but if you'd like to kick us off, and thank you for hosting us yesterday evening at your beautiful facility. And
Mr. Chairman,
yeah,
I just wanted to thank you for asking for public comment from the regular public first. Thanks a lot.
yeah, we try when we can. Welcome, Mr. Mincy. Floor is yours. Talk to us about prior auth.
Yeah, good morning, Chair Baldwin, Chair Zwanitzer, senators and representatives. Thank you for coming to our facility yesterday. It's always a pleasure to talk about what we're doing. Prior authorizations is a part of a bigger challenge for healthcare. One of the things that we run into in healthcare is overly burdensome regulation and overly burdensome contracting with insurance carriers. Just to give you a snapshot of what healthcare looks like, a facility here in Saratoga, I have 7 full-time RNs. I have 3 full-time LPNs. 2 of those full-time RNs and 1 of those full-time LPNs spend as much as 75% of their time doing administrative work. Look at my business office in comparison. I have 14 full-time people working in the business office. Their job is to deal with insurance companies and regulations. Prior authorizations, I have 1 LPN that spends anywhere from 8 to 10 hours a week just on prior authorizations. I have 3 other full-time employees in the business office that also spend 8 to 10 hours every week dealing with prior authorizations. The vast majority of the time that they spend on prior authorizations is on hold. They will spend 45 minutes to an hour on every single prior authorization. As I was talking to my staff this last week about their input into this, my clinic nurse said, you know what, if everybody would do this website, and I'm sorry, I don't know which website it was, but they said if everyone would do this website where I could take 5 minutes, put in the information that they need, and I can come back later and get an answer, then I can spend more time taking care of patients. This is not a challenging decision to decide, are prior authorizations overly burdensome? They indeed are. And I support this bill completely. It will improve the amount of time that my staff have to actually do what we want to be doing, and that's taking care of people. The burden that we see from the insurance carriers is it's the vast majority of our administrative folks' time. They want to tell you that it's about what we charge. It's about, it's all about we're the problem. I would challenge you to look at and see who the problem is when most of us are struggling to break even. We're relying on local donations and tax dollars to keep our doors open, and every one of them are posting billions of dollars in profits quarterly. It's not the healthcare provider that is the problem. So I highly encourage you to support this bill. I'm happy to answer any other questions you may have regarding this bill.
Senator Doxbetter, go
Mr.
ahead.
Chairman, support the bill as is, as you see it now. And again, thank you for that tour yesterday and wish you all the best with your facility, but support it as is.
Yes, sir.
And I know committee, we do have a couple of staff comments. We'll have to probably work there and just make sure we're clear on where we're going. Any other questions for the CEO? We got off easy today. Again,
Thank you very much. Hope you enjoy your time in Saratoga.
for your time yesterday and this morning. All right, no other public comment. Let me just check online. I think there are 3 industry people in the room waiting. And Ms. Herman. With that, insurance company, hi, Blue Cross Blue Shield. Welcome to Saratoga. It's a pleasure seeing you, Ms. Roday, and I think committee, you were provided a handout and a letter in an email 2 days ago with some suggested amendments in a priority order, which I appreciate. Welcome, Ms. Roday. Floor is yours.
Morning, Mr. Chairman, members of the committee. My name is Heather Roday, and I work for Blue Cross Blue Shield of Wyoming. I'm joined to my right by Amy Skazwak, and to my left, my colleague Rocky Rudd. We are gathered here today to discuss some complicated pieces of legislation. And we are all collectively tackling complex topics where we are trying to balance the needs of those who are providing care with those who are paying the bills for that care. And these positions are naturally at odds with each other. While providers and hospitals are facing rising costs and inflation, so too are our members and our business clients, who are also our neighbors. We are indeed a Wyoming company, and most of our employees live and work in Wyoming. While we bring forward comments about legislation which will impact our members, we are doing so not to protect profit margins. We are doing so on behalf of our members who are at risk of paying more through increased premiums and cost shares. We hope that as discussions continue today, you'll consider both sides of these issues and the impacts of the decisions on Wyoming consumers. Blue Cross Blue Shield of Wyoming wants to pay for appropriate care, and we do not use prior authorizations just to avoid paying claims. Prior authorizations are important for ensuring members receive safe and effective health care while protecting their healthcare dollar. However, we also acknowledge that there is indeed room to improve the prior authorization process. So through many discussions and a comment period in July, we offered our thoughts on prior versions of the current bill, and we appreciate the incorporation of some of our suggestions by Senator Dockstader and Representative Penn and other stakeholders. However, we continue to have concerns, and we offer the attached amendments that are before you to address them. Our priorities are not in the order presented by the amendments, but are as follows, and we talked a little bit about the prioritization. So number 1, the required consultation with providers before a claim denial presents some concerns for us. With an average of 20 claim denials occurring every day, this language will require our pharmacists and medical directors, who are physicians, to spend, in some cases, over 50% of their days contacting providers and members. At this point, we still need to understand how the logistics of this request will actually help speed up patient care without taking up more time in a provider's day. And so therefore, we respectfully suggest that this language be removed. So number 2, we ask the timeline for urgent prior authorization requests to be changed from 24 hours to 72 hours. It's important to understand that urgent does not mean emergency, as insurers are not allowed to have prior authorizations for emergency services due to the No Surprises Act. So there is an AMA report that showed 4 states with a 24-hour turnaround, and 12 states with 48 hours, 12 states with 72 hours, and 19 states that did not have one turnaround time defined. We are concerned a 24-hour turnaround will adversely impact members. And from another stakeholder letter that was submitted recently, we do appreciate the willingness of others to give us 72 hours. The definition of healthcare services needs to be further defined into inpatient, outpatient, and prescription drug. The timing of prior authorizations lengths vary according to the type of service. So 1 year is not appropriate for all prior authorizations. For instance, if we have a 1-year authorization for an inpatient claim, we expect that will be denied. because we would not ever do that. So number 4, we are concerned that the practice of gold carding will continue to contribute to misuse if providers do not abide by established criterion and perform services which otherwise would have been caught by prior authorizations. And Amy actually has an example of this.
Good morning. In 2018, Blue Cross Blue Shield of Wyoming ended its gold carding process. We had a gold carding process for many years on the outpatient procedure code side. During that time, we felt that there may be issues, but we were unable to find those in the data because we weren't receiving the prior authorization records. Blue Cross Blue Shield of Wyoming has a smaller staff, and at that point in time, we did not have the ability to do aggressive post-payment auditing, meaning when the claim comes in, we do not wish to order records and slow the payment down to the provider. We found when we closed the gold carding process that we had clinics who were rendering services not in accordance with medical guidelines and that were raising premiums. So an example that we saw was one of the largest dermatology clinics in the state was rendering Botox for cosmetic purposes under the idea that wasted units were being utilized and non-wasted units were being used for medical purposes. So for example, Blue Cross Blue Shield of Wyoming covers or allows use of Botox for the treatment of migraines. Typically, Botox comes in a certain prescribed vial size from the manufacturer of the pharmaceutical. For instance, if a member needed 80 milligrams of the drug, but the vial came in 100 units, the provider was rendering 80 units for medical purposes and 20 units for cosmetic purposes. But Blue Cross Blue Shield of Wyoming received the entirety of the claim. Those 20 units should have been the member's responsibility, not the insurance company's responsibility. When this practice changed, we saw an increase in denial rate in the dermatology community that was substantial and greater than 30% jump in denials. Our concern is that there are areas of medicine like this where there could be these unintended consequences that we may begin to see. And those may impact the member who did not have a chance to be part of the conversation prior to services being rendered, meaning the insurance company then denies a portion of the claim that then becomes the member's responsibility after services are rendered.
Thank you, Mr. Chairman. So based on our actual experience, we suggest that this section be deleted. For prescription drug prior authorizations, it is important to include FDA-approved dosage and duration criteria in the language because it is the Federal Drug Administration, the FDA, who determines how drugs should be safely and appropriately used in the U.S. So number 6, regarding opioid abuse treatments, we acknowledge that there is an opioid abuse epidemic. However, our pharmacists have shared concerns with us about that without any prior authorization, the prescriptions used for treatment can also be abused. Our current practices apply quantity level limits on the treatment drugs and encourage visits with providers periodically to ensure their safe treatment. Without the ability to apply evidence-based quantity level limits to the treatment drugs and encourage members to check in with their providers periodically, we cannot support this language and would like it removed. When state legislation impacts benefit design, it is preempted by federal ERISA law, and therefore we request the removal of reference to coverage on page 20, and I believe Mr. Spencer will talk more about that. The final request is a nice to have, so we would like to have the flexibility regarding urgent definition for mental and behavioral healthcare services and would like to change the shall to may. And that is amendment number 2. So this is our prioritized list. We hope the committee will consider these suggestions to improve prior authorization process from the current state, and we stand for questions.
And then, so committee, we will probably deal with these as amendments at the appropriate time after, and then if we need to call back any of our people testifying on some of the amendments as we work the bill, we certainly will. At this time, does anybody have any questions? Representative Ward.
Thank you, Mr. Chairman. Did you deny prescriptions for ivermectin during the scamdemic?
Ms. Roday, or if you know.
Mr.
ahead.
Chairman, Representative Ward, we do not know.
And if it's possible in the next, I don't know, 2 or 3 hours to find out, and maybe check the records and see, if you'd let us know, that'd be great.
We can do that.
Other questions at this time for Blue Cross, Blue Shield of Wyoming? Not seeing any, Mr. Spencer, while you're up there.
Thank you, Mr. Chairman. Good morning, members of the committee. Mr. Chairman, Bruce Spencer, representing the Mountain Health Co-op. I'll make a couple of just overall arching statements and then get into the amendments. I understand prior authorization is a thorn in the side of providers. And that's why we health plans have worked to try and craft a bill that is fair and equitable and does address some of the concerns providers have about prior authorization. But insurance companies are fiduciaries of the funds that individual people in Wyoming give us to pay for claims. We can't just throw the money out and expect it to be there when claims are need to be made. And so the prior authorization process is part of that fiduciary responsibility that we have to ensure that that money that is given to us in good faith is spent well and wisely. Now, you hear all kinds of different policy arguments, pro and con on prior authorization. I will tell you emphatically, there is no nefarious intent in prior authorization, at least from my company, Mountain Health Co-op. It does not exist. The prior authorization is not designed to prevent adequate patient care or proper patient care. It is designed to help with our fiduciary responsibility to that member. Now, of course, there's necessary tensions in the process. Anytime somebody is telling somebody else that we're not going to approve something, you have necessary tensions. That's what this bill is about, is to maybe ease those tensions and make it easier. Mountain Health Co-op agrees with the amendments presented by Blue Cross Blue Shield. I do want to talk about one in particular that Mountain Health Co-op presented in its letter and amendments to you. And that is the continuity of care for enrollees, 2555-112. It's on page 20 of the bill.
What page of the handout you gave us?
It's on page 4 of my handout, and it would be
Committee, it says lots of Bruce Spencer, that cool shield.
correct. Yeah, that's my family crest. How about that?
Really? Nice.
Yeah, my dad had that on his store, retail store, for 30 years, and I'm proud to be able to continue the tradition.
All right, page 4, go ahead.
And this is on page 20 of the bill for the bill language. There's subparagraph C in the continuity of care of enrollees. And I apologize that I didn't bring this up sooner in the process, but sometimes when you're reading through things, they just pop out at you. And as a lawyer, this time this popped out at you. The first sentence of subparagraph C says, if there is a change in coverage of or a change in approval criteria for a previously authorized healthcare service, basically that person is grandfathered in for 1 year. Well, there isn't a problem with change in approval criteria, right? I think we all agree that if you got prior approval and the insurance company then changes the prior approval criteria, you shouldn't have to go do it again. So the 1 year is fine with that. But I do have a big concern with the use of the term coverage of. And I think this is just an unintended consequence. I'm not exactly sure what was intended here. But change in coverage of means that if an insurance company decides in, say, let's use 2024 as an example. If an insurance company decides in 2024 that they're not going to cover a certain procedure, it's not provided for in the policy, We don't pay benefits for it. Or we change the deductible amount or the copay amount for that particular procedure. Okay. What this bill says is that if you got a prior auth for that procedure in February of 23, now you are in a special class of person that isn't subject to that decision to remove that procedure from coverage. And so now you have two different classes of people. You have regular members who haven't gotten prior authorization that are not covered for that procedure, and somebody that is covered because they got a prior authorization up to a year before the change in coverage. I don't think that the legislature wants to step in and engage in benefit design, which is what that does. Okay, it prohibits a plan from saying we're going to change the benefit that we're offering in the plan on certain procedures for anybody that received a prior auth up to a year before. That's, I think, a step too far, and I'm not really sure it was intended. I'm not sure that that was intended. So I do have, as a lawyer, a big concern about that. I think it could cause problems legally for the bill in the future if it's there, and it's an easy fix. You just have to take out the word coverage of in that paragraph. You just remove that and that problem goes away. As I said, we agree with Blue Cross Blue Shield on their suggested amendments. I did provide amendments in order of priority for Mountain Health Co-op. That order would be to address the 24-hour turnaround on urgent. I think it's important for the committee to understand the difference between urgent and emergency. I know Ms. Roday mentioned that. These are not emergency situations. This is an urgent situation, and we're asking for 48 hours, 72 hours to review that. And that is consistent with every other state that Mountain Health Co-op does business in. I need to get to page 12 here. Should have done my amendments there. Yeah, so we also have concerns about the consultation required before a plan is going to deny in prior authorization a request. And the bill says that the plan has to reach out to the physician, and then they have the opportunity for an in-person consultation. That creates a level of bureaucracy that is not in any other prior authorization bill that Mountain Health Co-op has to address. And as you heard the gentleman from the hospital say, they spend a lot of time on their phone waiting for conversations. Well, this creates more conversations, not less. Creates more bureaucracy, not less. And unfortunately, we believe it provides the opportunity to throw a wrench into the timeline of the process. If we have currently 24 hours on an urgent request, if that's changed to 72, and there's delays in having a peer-to-peer conversation with that physician, what does that do to the timeline? Is then the procedure automatically approved and our prior authorization process nullified because people are busy and we can't have that call? And with Mountain Health Co-op, they get the opportunity for that peer-to-peer conversation. They can have it. And if the procedure is denied, they can have that peer-to-peer conversation, and that decision may very well be changed during that peer-to-peer conversation. We don't feel that that provision is necessary. And so we encourage that change. Finally, Mr. Chairman, if you will indulge me in, I want to address something I've never in 31 years of practicing law or 25 years of lobbying had to do. Now, one of the comments submitted to this committee said that my client, Mountain Health Co-op, submitted a patently false statement to this committee. Well, I wrote those comments. I sent them to my client for review and approval, and then I submitted them to you. And I want to explain why that allegation that I submitted a patently false allegation to this committee is so important and vital to what I do. As a lobbyist, all I have, and a lawyer, frankly, all I have is my reputation with you. I have nothing else. I am here to provide a resource to you. I want to answer your questions and I want to provide you with information on important public policy matters. The public policy matters you're hearing here today affect hundreds of thousands of people and involve millions and millions of dollars. And I know that. And as part of that process for 25 years, that public policy process, I know that my information must absolutely be accurate when it is given to this committee. I can't operate by the political campaign standard of, well, maybe down in a footnote in a committee or a hearing or an ad 3 years ago, I'll get to make some statement. I can't operate on that standard. You should demand from me and every other person that appears here absolute truth. Nothing less is acceptable. And so that allegation is incredibly damaging to what I do and in my belief in this public policy process. I have an ethical obligation as an attorney to give candor to courts. I cannot tell a lie in court. Well, I feel I have that same ethical obligation before legislative panels. I would never breach it. You know, the disturbing thing to me is that I never received a phone call or an email saying, hey, Bruce, we have a concern about this statement. Can we talk about it? No. Instead, what we receive is a publicly filed document accusing my client of providing you with statements that are patently false. That is not the case, and I assure you, I would never do that. I respect all of you too much, and I respect the process too much. So I appreciate your indulgence, Mr. Chairman. I am happy to stand for any questions on any of the amendments discussed and give you my client's perspective.
Appreciate that, Mr. Spencer. Let me throw a question at you because Mountain Health is also in Montana. What is the urgent turnaround time in Montana, if you know?
Mr. Chairman, members of the committee, it's 48 hours in Montana.
And for at least your client, have you heard, how long has that been in effect? Are there complaints? Do you always meet that benchmark or 98% of the time? Any other information you can give this committee?
Mr. Chairman, members of the committee, it has been in effect since I think 2019, maybe 2017. It is a challenge to meet that benchmark. Our TPA, University of Utah Health Plans, invest significant amounts of resources to meet that 48-hour turnaround. They felt that 72 hours is much more attainable. Do we have complaints about them not meeting that? I'm not aware of any. Right? It's just that it costs money and staff and time to meet that turnaround. And with that consulting requirement that we have currently in the bill, it's going to cost physicians money, staff and time, and providers money, staff and time to meet that requirement more than now.
Other questions from Mountain States Co-op? Not seeing it at this time. Thank you much. Oh, yep, Senator Doxter.
If you had your preferences, Mr. Spencer, on this list, working with Blue Cross Blue Shield, which you're working with too, would you put a highlight on 2 or 3 of those that we would want to really put an emphasis on, or is it just all of the list or none of the above?
Well, Mr. Chairman, Senator Dockstader, all of the above. So certainly the discussion that we're having about the urgent turnaround time, that is of paramount importance. My folks at the University of Utah Health Plan told me 24 hours is a standard that is very, very difficult to meet, and they don't feel they could do it at this point in time. You know, we're not a big big multi-conglomerate insurance company that has the ability to program all this, so it's all electronic at this point. We're all working towards that, but we're not there yet. That requires significant resources. So that would be number one, to agree with the providers in their letter that a 72-hour turnaround time is appropriate. Do you have your list of amendments? Maybe I can just take a look at 1, 2, 3. Sorry, I gave you my list, but I didn't look at their list. I do agree with their list. So that would be my heart. The second one is that care coverage that I spent some time discussing about. That would be our second priority. And then finally, I have to go to my amendments, which are always difficult because I did put them in order. Yeah, removing on page 12 of the bill lines 1 through 15. Which is that consulting prior to the adverse decision. Those would be our top 3.
One more, does Montana have what I guess this bill considers gold carding? Do you operate in that system in the state of Montana?
Mr. Chairman, members of the committee, that is now a slightly complicated question for Montana. We had a standard gold carding bill submitted last session. It was probably not going to pass. And the mental health care providers wanted some gold carding standards for specific drugs that they use. They're really urgent in certain mental health circumstances, suicidal folks. And so we entered into a compromise where those providers, if they meet a 90% standard, not an 80% as is in this bill, those providers only those certain drugs have a gold card ability in Montana. But we do not have a general gold carding bill.
Quick follow-up.
Yep, go ahead, Senator Doxter, Member Representative Clausen.
Mr. Spencer, we respect your professionalism and your integrity. And if a member of the body left that in question, I will apologize. But you also have the avenue of bringing up that matter if it is a member of the legislative body with the leadership team of the committee and the leadership of the legislature as well. We try to keep this respectful and keep the dignity involved. Times we stumble, and just leave that option open to you. Appreciate your work, appreciate your integrity, and appreciate the tradition of your family shield. Thank you.
Mr. Chairman, Senator, thank you. It was not a member of the legislature. It was a comment that was submitted to this body as a public document.
Thank you for your follow-up. Anyway, appreciate it, sir.
President Clausen, you have a question?
Yes, thank you, Mr. Chairman. To any of you, I guess, one of the problems in Wyoming is we're the only state without prior authorization. And as you're trying to get things authorized, there's a huge difference between every company that you work with. When I look at the 24-hour urgent and then I look at the 5-day for other authorizations, I mean, now we have an hour thing and we have a day thing. And also as a provider, you're gonna have to figure out, is this urgent or not urgent? How would you feel if it was 72 hours period? Keep it consistent across all plans. That way the providers know exactly what to expect. The insurance companies know what to expect.
So, Mr. Chair, Representative, I'll start out because my company does write in 3 states. And in all but Wyoming, and we absolutely agree, Wyoming needs some additional prior auth. You have some already, by the way. It's not true that you don't have any prior auth regulation in the state. You have some, but you absolutely need additional, and we're not disputing that. All of our other states are exactly that hybrid. Okay, it's an hours for urgent, and then it's 5 business days for non-urgent. That's the standard in every other state. We have no problems complying with that. And everybody understands generally the difference between an urgent request and a non-urgent request. That we just haven't seen those kinds of administrative problems with us. I'll let Ms. Roday or someone answer if they wish.
Mr. Chairman, Representative Costin. I think that's a good question. I agree that we do have some prior authorization framework here in Wyoming. The one thing I will say about addressing your specific question is if all of the prior authorizations were set at 72 hours, it may be hard to sort of prioritize those urgent requests over the top of something that's more of a general and regular request. So it might just get caught in the same bucket. And we do, in fact, want to prioritize anything that might be urgent, anything that might be causing pain to a member, anything that might be sort of putting them in a space where their life might in some way be put a challenge. And, we don't expect to wait a full 72 hours. If we get an urgent request and we can answer it within an hour, of course, we want to do that. It's just a matter of timing. It's just a matter of the amount and the volume that we receive. So I could see that being a challenge. And I think it does make some sense to set them into separate buckets. I may defer to Amy over here for some additional comments, but just to answer a couple other questions, if I may. Representative Ward, in the spirit of being open and honest with the committee, we have denied ivermectin requests for not meeting utilization management requirements. So I did want to let you know that our pharmacist just texted me and let me know that we have done that. I don't have all the specific details for you, and I can provide that if you'd like, but I can confirm that we have denied those requests. And then I wanted to make one other comment, which is a representative from the local hospital here made mention of a website. And I think what they were referring to was our Availity website that Blue Cross Blue Shield of Wyoming uses. And that has been a very good tool in the prior authorization process, I think, for providers. It does streamline the process. It does make it a lot more simple. And I do think that a lot of the providers in the community like it. We've been trying to provide more education on it so that it can be utilized more. I think it is underutilized, but if it were to be utilized more, I think a lot of the providers in the community would appreciate it. So the only other thing I would say is, the comments that we provided today were in no way meant to be offensive in any way or to members of the provider community or anything like that. Like I said, solutions like Availity and other solutions out there are a little bit less, I guess, prescriptive than some of the rules that are set out in this bill. And, looking at this bill and some of the requirements that are in it, it looks, and this is just my personal opinion, to be setting a precedent to start putting things in sort of the AI track. And that's not necessarily something that we want to do, right? I mean, we would prefer to allow a human touch, people to be reviewing things, our local doctors and physicians to be able to look at things, as opposed to just sending them into a computer system and spitting them out at people. So that's everything for me.
Oh, Amy? Okay. Can I ask, I guess, one more question then? When it comes to this kind of gold carding concept, are there internal mechanisms where you could internally say this mental health provider sees high-risk patients on a routine basis, we haven't had any concerns, and there's a note in the system that, absent other information, they get approved kind of automatically? I mean, do you need a statute to tell you to allow gold carding? If you as a company wanted to do something similar, call it whatever you want, could you institute that internally?
Thank you for the question. From Blue Cross Blue Shield of Wyoming, there are mechanisms that could allow that practice. Since 2018, we have solely focused on removing authorization requirements at the code level. So instead of focusing on one provider or two providers in a space, say, can we eliminate prior authorization in that space for a particular procedure? One of the items we have seen as a company that is difficult to navigate is sometimes the larger practices have a larger voice. They have the amount of claims that we can really go through analytically and say, this is a provider who should be given some allowances. But what that does is it does not allow for the smaller practices to see that impact. And typically the smaller practices are who have difficulty with the prior authorization process. Different insurers have different requirements and rules. So when you're a small practice trying to navigate that, it's very difficult. So we felt we should look at the larger picture than at a provider specific picture.
Makes sense. I'm sure the larger practices have people who are full-time devoted to working with you, and you are on a first name basis and talk to them every hour or two. And that relationship does mean something that's not just electronic. Any other, Representative Penn?
Thank you, Mr. Chairman. Could any of you and maybe each of you give me an estimation of what you think the rates of urgent requests versus non-urgent requests are that you process?
For Blue Cross Blue Shield of Wyoming, on the inpatient side, so inpatient hospital care or other like facilities like skilled nursing facilities or acute rehab, urgent requests are typically around 50% from their submission. On the outpatient side, typically from initial submission, it's around 60% are submitted as urgent. When we look at processing them, though, our physician staff, not our nurses, our physician staff does change that urgency, and we usually process around 10% as actually urgent. Our largest category of urgent submissions is the dermatology community or the orthopedic community, which is typically not seen as urgent care.
Mr. Chair, Senator, Representative Penn, I don't know the specifics, but I can't imagine that our population is all that different from Blue Cross in Wyoming. So I imagine it's a similar percentage. I do not know whether or not the physicians at University of Utah changed that designation. I can find out if it's very important to you and get back to you.
Representative Hornock. Any follow-up questions from the pen? Okay, Representative Hornock.
Thank you, Mr. Chairman. I'm just looking through how many states have a 24-hour urgent care prior authorization.
I believe it's 4 on something I've read today, but Ms. Roday, do you know?
Mr. Chairman, Representative Hornock, according to an AMA report that lists all of the different states, when we waded through all the different sections, it looks like there's 4. Kentucky in 2019, Alaska that did not have a date, Arkansas in 2018, and New Mexico in 2019.
Good.
Yeah, follow up, Mr. Chairman. You may be right. I'm looking, it seems like there's a few more than that, but it might not be for urgent care. It might be for emergency or something like that. So there's kind of there are precedents for the 24-hour care with states that have a lot, I would say, a greater population than Wyoming. Why wouldn't this be possible in Wyoming with a small state with, we don't have 2 million people that are going, so many hospital visits in other states. Why wouldn't this be possible in Wyoming?
Whoever wants it. Welcome.
So a couple of items that are difficult in the 24-hour time frame. One is truly resource allotment. So at Blue Cross Blue Shield of Wyoming, we employ 2 medical directors or MDs that are making decisions, and we have a nursing staff of 9. Typically, our 2 medical directors who are making those denials are also practicing physicians. So the resource capacity to run 24 hours a day, 7 days a week would be difficult for us initially. Obviously, you can always hire additional individuals and resource, but that does come at a cost. Secondarily, 24 hours is difficult with the consultation piece of the bill. So I do worry about when we're reaching out to providers, if it was a 24-hour time period on a denial, to say, can we have that conversation? Many of our practices in Wyoming are not open 7 days a week. Many of those that would be receiving denials would not be available for those consultations 7 days a week. Another issue that presents itself is some of our larger institutions in the state, especially hospitals, use outsourced billing companies for authorizations. So again, they're working 24 hours a day, 7 days a week, but our provider community and our payers are not always working those same schedules. So an authorization that comes in on a Saturday may not have a treating physician available to Blue Cross to speak to, nor do we typically have staff working those hours. So it makes it difficult.
Any other questions, Representative Penn?
Thank you, Mr. Chairman. I guess I mostly just want to clarify on the bill. So the consultation piece is on page 12, 25, 50, or 26, 55, 106. And it doesn't require that the consultation take place. It just says that the opportunity, that there must be a notification, that there may be a denial, and then the opportunity is there for a consultation. So it's not requiring that.
Mr. Chairman, Representative, that's correct, except you have to take that step. You have to reach out to that provider. The provider has to get back and say they don't want a consultation. And especially with a 24-hour urgent turnaround time, we are extremely concerned that that's not going to happen, and that abrogates the prior authorization process. Even with a 72-hour urgent turnaround time, that's a concern. And frankly, it has the potential of creating a bottleneck in the whole system where one isn't necessary because if that provider just isn't available, they're extremely busy. We get it. But says they want a consultation. How many days might that take? And we have some timeframes we have to meet, which is fine. But this particular section really creates that potential for bottleneck, and that's why we have the concern.
So can I ask a question? Who decides urgency? Is it sounds like people put in claims that say these are urgent and you say these aren't urgent. Is it a code that these are urgent codes? Or does the submitting practice physician, et cetera, say, well, this one's urgent? How does that work?
So typically there's not a code for it. It is words written on a piece of paper. So typically we'll see urgent, expedited written on it. And then we take the medical records and present those to a physician and ask them to review those against the Department of Labor's urgency standards, which is also very similar to Chapter 63 in the Wyoming State Code.
So do you ever, I guess, respond to, I would assume, a clinic or a hospital, that says everything is urgent to say, quit doing this?
We do, and we have. At Blue Cross Blue Shield of Wyoming, we don't have any provisions to stop the practice, so there's nothing in our contracts. So we do have those conversations, but it doesn't seem to change the submissions. However, with our website that is available to our providers now, in real time, they can see that change in determination. And there's also an ability to see the comments from our physicians to see why their urgency has been changed, so that there is real-time communication between the provider and Blue Cross Blue Shield of Wyoming.
So even if we made a 24-hour urgent timeline, I'm not saying you would, but you could say, well, no, this one isn't urgent and we have 3 days at your discretion. It just, something doesn't make sense to me that if I were a provider and I wanted, I would tell the patient, we put in an urgent request, we'll know in 24 hours. And then it's the evil insurance company, is still holding back, even though it's maybe not your fault. Is there another way to fix this besides the word urgent and who gets, if it's by code, I can see, but otherwise everybody says something is urgent, which means nothing is urgent.
Yes, and we would agree with that. That's the principle that we're trying to work through. Our hope is that with our online tools that are available and continuing to enhance those, that we, being more transparent and providing that on each individual authorization, can possibly serve as an education mechanism to provider staff in helping them see that changing this does not actually change the timeline. But depending on the language of the bill, we may not have that ability.
All right, any other question? Representative Ward?
Thank you, Mr. Chairman. I just had a thought about the 24 hours. What if it were 24 or 72 business hours? Or on a business day? Would that help?
Go ahead.
For Blue Cross Blue Shield of Wyoming, yes, business day is a term that we enjoy more than the 72 just hours. So I think that is something that we could definitely look at or work to. Bruce?
Mr. Chairman, Representative, in stakeholder conversations on urgent, I believe the provider community is very concerned about putting business day in the 72-hour or 24-hour requirement. It is in the non-urgent. It's 5 business days after we receive all necessary materials. So I know they have great concerns over that, and I will represent that. I know we can comply with 72 hours, not business days, on the urgent. And I believe the providers in their letter to you indicated that that was acceptable. And so we would urge the committee to sort of say, well, you guys have agreed on that. Terrific. But it does need to be, because the providers are very concerned. And I think with some justification, they want that as hours, not business days.
All right, we'll get you out of the hot seat for now. I'm guessing you might come back up here in a bit. Other comment? Anybody who really wants to go next? Otherwise, I might. Oh, Kevin, come on down. Welcome to the Board of Medicine. The floor is yours.
Thank you, Mr. Chairman, members of the committee. My name is Kevin Bond. I'm blessed. I'm the executive director of the Board of Medicine. And the board doesn't usually have a dog in the fight, if you will, with insurance bills. And so that's why I'm late to this party, and I apologize first for that. And second, as LSO staff pointed out to me, I need to get better about labeling when I send you something. I've got something here with some yellow highlight on it. And if it was my wife's classroom, she'd say, if your name's not on it, you don't get a grade. So hopefully that won't apply here. But I only bring this to your attention because currently in the Wyoming Medical Practice Act, included in the definition of practicing medicine is the rendering of a determination of medical necessity or appropriateness of proposed treatment. And I don't know the history behind that, but it's in place, been in place for an extended time, at least in all my time at the board of 17 years. So my only concern then to just bring to your attention, and it's not a for or against, it's simply to bring it to your awareness, is that if you go to the second page, or actually in the bill on page 11 and then on page 13, there's basically a provision that allows for a person licensed in any U.S. jurisdiction to make a determination of a prior authorization on a prior authorization request. And that would seem to conflict with what the legislative intent was in the past to say that a determination of medical necessity is actually the practice of medicine or a healthcare profession. So what I've suggested as an option for you all on the second page of my unlabeled handout would be to go through on pages 11 and 13 and basically delete the language that says that that a person rendering a finding on a prior authorization would not be licensed in any state, territory, or Commonwealth of the United States or the District of Columbia. It rather would say in the state of Wyoming, which would be more in keeping, I think, with that intent in the Medical Practice Act to have some accountability for the professional making the determination in the state. And then last in that second page of mine would be suggesting to amend the provision in the Medical Practice Act to go beyond just medical necessity or appropriateness to say, or prior authorization for treatment pursuant to, and then the sections created by this bill. Again, I'm not here to advocate or anything else, and I know you've got much bigger fish to fry, but I wanted to bring that to your attention so that you would know kind of what the balance is here. The board doesn't often get complaints like that, but we do on occasion, and I suspect the Board of Nursing may too, when they have nurses making determinations. And so with that, Mr. Chairman, I'll stand for questions or get out of the way for others. So.
Questions for Mr. Benоблast? Representative Hornock.
Thank you, Mr. Chairman. So we have heard from the insurance companies that it's hard enough with their limited staff in Wyoming to make some of these determinations. And we're within the bill currently, we've got a 24-hour time period, which complicates it even further. It would seem to me like if we opened up, I understand licensure specific to Wyoming and how important that is, but when you're dealing with just prior authorization, it would seem like it would open up the ability to have the 24-hour turnaround much easier if we extended the parameters to be licensed in the United States of America, essentially, because we have heard in the past also how we've all done it where you get on the phone, you get to you push 2 for this, push 4 for that, push 7 for this, listen, push 0 to finally talk to somebody. And you can hardly understand them because of the accent and who knows where they are. So, there's some limitations to all this. Do you see a major problem with what we're trying to do here to just open up the doors a little bit to somebody licensed in America versus having somebody housed in Wyoming, being a licensed physician to make those determinations here in Wyoming? Do you see a real negative consequence to opening that door? Thanks.
Go ahead.
Mr. Chairman, Representative Hornock, your points are well taken, and I don't disagree with them. And I think that on the other hand, for instance, the carriers that do carry the bulk of Wyoming patients on their book of business, to my knowledge, their physicians are licensed in Wyoming, but I guess it's just a question of accountability for that professional in making their rendering a decision, because like it or not, you're going to get then sort of whatever they manage to hire and have in an office in Nashville or whatever. Just a personal example, I've got profound hearing loss on one side, and had 2 different ENTs say that I could benefit from a procedure where I would have an implant put in, kind of like what Rush Limbaugh had apparently, but not quite. And was told by the carrier, who happens to be the state employees plan, that no, that was not medically necessary, was not covered. So I simply said, well, what's the physician's name who made that determination? And they gave me the name. Well, the physician was licensed in Tennessee. Okay, and so they'd still be okay under this bill, but they were also a urologist. And I thought, my hearing's pretty bad, but I'm not sure it's ranks getting a urologist to make a decision on this. And yet that urologist is practicing outside the scope of his training and skill, which would be a problem. But the Wyoming Board of Medicine probably could not touch them because they weren't licensed in Wyoming. So all I'm saying is that's just something, you can't move one piece without causing something else to move, but your points are well taken. It's not a simple solution. I think if we want to go the simplest here, perhaps not changing the language of the bill, but just including in the bill that prior authorization decisions are considered to be practice of medicine. At least you're going to be held accountable to that. That I think would at least get us partway there.
Yep. Representative Clausen.
Thank you, Mr. Chairman. Thank you for your testimony. I don't think it would be difficult for an insurance company to hire a physician who lives in Tennessee, but actually has a Wyoming license. I don't think it'd be difficult for them to apply and get a license in Wyoming. Do you think that would be an arduous task for them, or how do you see that working out?
If you want to comment, we could always ask them too, but go ahead.
Mr. Chairman, Representative Clausen, I can only speak to what our experience is. We have about 6,500 doctors licensed in Wyoming. Only about 1,400 live in the state. And they are licensed for all sorts of different practices and purposes, not the least of which is doing review of prior authorization requests and so on. We're also part of the Interstate Medical Licensure Compact. A lot of the larger national practices have been putting their physicians through that. And if it came up that they need to have a Wyoming license and they're already in the pipeline for that, it's as simple as saying, here's my credit card, I want a Wyoming license, and we issue it within a very short period of time, usually 24 to 48 hours. So it's not an impossibility, but again, if you've chose to split it, I would say if you can just see your way clear to include determination of prior authorization determination with that language in the Medical Practice Act, I think that would at least make it clear that we can look over the shoulder of a physician who is making these determinations. And if it's a urologist, just ask them what their experience is in ear, nose, and throat surgery.
All right, other questions? We'll take up that amendment at the appropriate time. Thank you.
Thank you, Mr. Chairman, committee.
Ms. Settles, just for the nursing while we're on boards, anything on this bill? And then maybe we'll just start in that side of the room and go across. Welcome.
Good morning. Thank you, Mr. Chairman. As Kevin mentioned from Board of Medicine, same for our APRNs. We would ensure that they're practicing within their scope and foci. And currently, we have approximately 1,900 APRNs licensed in Wyoming, with 700 of them being home addresses.
And I know I called you by name, but if you just introduce yourself again to us.
Thank you. Rachel Settles with the Board of Nursing.
Right. Any questions for the Board of Nursing? Thank you for being here again today. Sir, come on down. Welcome to Labor Health. Floor is yours. Just make sure that green light's on the microphone.
Good morning, Mr. Chairman and members of the committee. My name is Angus McAlpin. I'm an internal medicine physician in Lander, Wyoming. I'm a primary care provider at Lander Medical Clinic, and I'm here today as a community provider and member of the Wyoming Medical Society Board. First, I'd like to thank you for your time and attention to an important issue in medicine right now. I think the bill as written is an important step in improving the prior authorization process and in removing barriers to care in Wyoming. I can largely speak to primary care as that's where I practice, but I think my comments will apply to medicine in general. We provide, as primary care providers, comprehensive care to complicated patients. We manage specialty care arrangements, and we are champions of preventive services that lower costs and improve outcomes. Prior authorization is a significant administrative burden, and this burden is often cited as a source of physician burnout and part of the reason why there is an exodus of providers leaving primary care. In my practice, I rely on expert guidelines, peer-reviewed journals, real-time online resources to make my medical decisions, to provide evidence-based care. The prior authorization process is not part of this. In fact, just the opposite. Sometimes authorizing a medication involves trials of outdated medications, less effective or even riskier medications that conflict with expert guidelines. Regarding adverse determination, I think that direct communication is essential. This process would ensure a careful review of the medical record and any unique aspects to this patient's particular case, as well as a potential discussion between knowledgeable providers to come up with the best plan of care. Regarding the gold carding, the notion that providers that are given exception for requirements that they would fail to adhere to standards of care is offensive, and medical decisions are never guided by prior authorization. Thank you, and I'll stand for questions.
Questions for Dr. McAlpin? Let's start with Senator Doxter.
Dr. McAlpin. What you're saying is prior authorization and its associated timeframes do not factor into the decisions you make for your patients then, correct?
Whether there's a prior authorization requirement or not, is not part of my decision. I would assess the patient, figure out what it is that they need, and based on expert guidelines, evidence-based medicine, make a plan of care. The prior authorization comes later. If I prescribe a particular medication, if that prior authorization process is required, that does not guide my initial treatment plan.
Thank you, Mr. Chairman. Just want to go back to something you said, just so I'm clear. Obviously, we have a, limited staff in Wyoming to draw from for medical services, but you said that sometimes you've seen prior authorizations being the reason that people leave the industry. Do you have personal experience with that, or I just want to make sure I heard that right.
Dr. McAlpin?
The prior authorization process is part of this enlarging administrative burden that's placed on practices. And it's that administrative burden that I think is driving some provider burnout and causing people to leave primary care.
Other questions for the doctor? Yep, Resident Penn.
Thank you, Mr. Chairman. I just want to say hi, Dr. McAlpin. We are coworkers. We work in the same clinic. So to speak to what Representative Hornock just said, and I think how I see it, and I'll ask your opinion as well, Dr. McAlpin, is I think part of the burnout is that doctors oftentimes are not being allowed to practice medicine. It seems like oftentimes the insurance companies end up being the one that practice the medicine. We just try to decide what we think are best for our patients. And then later on, we get told that that's not not best, even though we are the ones that are sitting in front of those patients, toe to toe and trying to make the right decisions. I might liken it to teachers who are leaving the profession because they're not allowed to teach. They're not focusing on what is most important. They're focusing on all these other administrative things and other things that may not actually be best for those kids. And so I might suggest that maybe some of that is where this is coming from. Would you agree?
Would you agree?
Absolutely.
Follow-up questions? Okay, anybody else? Representative Clausen.
Thank you, Mr. Chairman. Doctor, thanks for being here. I guess I have a concern if you as a physician order a service or a medication, say a patient needs that medication, they go to the pharmacy that day. And then they have to wait now for prior authorization. I mean, do you see that happening? If my son's hurt and he needs some pain medication and I go to the pharmacy, I want to get that medication. And then now, does the pharmacy have to call you? Do they have to call the insurance company? Is there a delay in care because of the prior authorization?
Yes, I believe there is a delay in care. I can think of countless examples of situations where I've prescribed a medication that requires authorization, and there is a significant delay, and that can result in harm, in my opinion.
Okay. All right. Thank you much for being here today. Certainly stick around if you want.
Thank you very much.
Jamie, anything on? Oh, yeah. Well, Sheila's going to beat you up, but after that, you can be up next. But yeah, while we're still on Medical Society and doctors. And you're being joined by hospitals today on this one. Welcome.
Good morning,
Ms.
Mr. Chairman, members of the committee. Sheila Bush with the Wyoming Medical Society. I have brief comments prepared, but I wanted to address a comment made earlier regarding an accusation. And I think it's important just to be really clear about what that was. And so the Medical Society emailed all of you privately yesterday, an email with an attachment. It's a 4-page letter written by our physician leadership, signed by our president. And so the language that was addressed earlier, I'm going to read to you just because I think it's important. If we're going to talk about it, let's talk about it. So it says Mountain Health Co-op, MHC, suggests that if a patient stopped taking a drug due to lack of efficacy, the prior authorization process informs providers and permits a different therapy to be ordered. This statement is patently false. Never have I, President Chamber, been informed by the insurance industry's prior authorization process that a patient is not taking a medication and that another one may be prescribed. In fact, I know this information because I continue to follow each patient. If the patient is not adherent, this also will bear out within my follow-up evaluations, again, regardless of length of the prior authorization approval. Furthermore, the patient is not going to pay and pick up a medication that they are not taking. We know this because we speak with our local pharmacies, and it is partially the reason that we can identify non-adherence to treatment plans. So this was written in in response to section 2655-111, which has to do with the length of a prior authorization being 1 year. So I think what's possible is that, like so many things, there is what is in policy. It may or may not be that it's the insurance policy to talk back with the provider and say this medication isn't available, and instead we'd suggest these. I think what is also true is that when our physician leadership, I have a 26-member board, multiple physicians reviewed this letter. They all agreed that it was true. This morning when the issue was raised, I texted all of them in a panic, as you might imagine. Nobody wants to be accused of misleading or any of that, and that wasn't our intent. I think what is true from our physicians is what may live in policy is not what happens in practice. And it's important that everyone be candid and transparent about what this law means and what the implications of it are for medicine. And if our practicing physician, the physician who drafted this statement in particular, has been in practice for 12 years and never once been contacted by an insurance company, if a medication has been denied, but instead learns in a follow-up visit with the patient, that's important. And so it isn't in any way intended to call someone a liar or any of that. That integrity wasn't intended to be called into question. What is important is these physicians do believe it is patently false that that's happening in their practice. And so I'll just sort of leave that there. Again, it wasn't ill-intended. It wasn't meant to accuse someone of intentionally misleading, but I think it does draw an important light to the difference between what insurance companies may believe is happening or would happen on a perfect day in policy and what that actually looks like in a day-to-day practice in a clinic, which is what's really important for the decisions around this bill. So with that, unless there's questions.
Yep, Senator Dockstader.
Thank you, Ms. Bush, for your professional follow-up and clarification. Appreciate that. I'd like to understand from your comments, the first, that a physician learns that his prescription, his regimen of care is denied is when the patient comes back and says, I was denied. There is no efforts on behalf of the insurance companies to work with that physician?
Ms. Bush, go ahead.
Mr. Chairman, Senator Dockstader, I lack the expertise to answer that in detail. We have a prescriber on the committee and Dr. McAlpin is still in the room. And I think if we want to get into the real logistics of how that happens, we should absolutely do that. We have two prescribers in the room. I'm so sorry, Senator Baldwin. It'll be years that I'll pay for this also. So I think if we want to get into the details of a physician assesses, diagnoses, sets a treatment plan, prescribes a medication, patient leaves, goes to the pharmacy. What happens between the patient and the pharmacy, I think, is important. Ms. Carroll is here. She can also speak to that. There's a lot of layers to this. I think that the initial comments submitted indicated that insurance believes that they, at that point, if they aren't going to authorize that medication, they call or directly contact the provider and say, we're not authorizing this medication. Do you want to have a substitute therapy or a different medication? And I think that what our letter said is that's not what's happening. The physicians aren't being consulted. But I'm already pretty far out of my depth because I don't prescribe and I don't see patients. So I would very much defer to the prescribers and the pharmacists in the room.
And we can certainly get back to that, do you want to, we have a couple prescribers in the room. Senator Baldwin,
Well, certainly.
I want to answer the question. Go ahead.
Thank you, Mr. Chairman. Just briefly on that, and I'll just tell you, it happens in a number of different ways, depending on the insurance company, et cetera. But typically when, I'll just use medicine as an example. I prescribe something, the patient gets a denial and I get a denial, a similar letter. And I don't know if Representative Penn's similar, but a similar letter, if not the identical same letter that says this drug that you prescribed is not authorized. Sometimes it'll say, here's your options. If you use these first and you fail on these. So that's one of the ways that I get it. But generally the patient gets the denial and the prescriber gets the denial. We both get it. And that may come through the pharmacist as well. Is another way, almost daily. I get a denial from a pharmacist on a medication who then, to my delight, they help me a lot trying to find the right drug or the right medication or find a way around that denial. So a lot of times the pharmacist will tell me that denial, but typically the patient gets the denial as well as myself. One of my, and I'll just throw this out there since I'm talking, I wasn't going to talk at all today, but one of the denials I get that's particularly disturbing to me is when I have a patient on a medication for a long period of time. I'll just throw out 2 years. And that patient is doing very well on that medication, be it an antihypertensive, an antidepressant, whatever the case may be. They're doing very well and very stable. And I get a denial from the insurance company or from the PBM or whoever that is that says, hey, this one's not authorized anymore. We'd like you to try these medications. It gives me a list of 3 medications. My patient is very stable on this medication. I don't want to change them, but because their formulary has changed, I now get a denial for that medication. And sometimes, I try my hardest to find a way around it, but we end up going back to another drug that it's a nightmare. And I think of my nursing home patients, my long-term care patients who are very stable, doing very well. And we throw their life into upheaval when that happens. That's very distressing to me. And I think I shared with the co-chairman this morning almost daily. And it seems like right before I come to these meetings, every time I get a handful of denials and prior authorizations that give me nightmares at night, but I have a lot to think about when I'm here. But that's typically the way it happens. Just to answer that question is that the patient gets a denial, I get denial, and then we try to work our way through it.
Wouldn't you agree, Ms. Bush? Because
I think it's in my best interest to absolutely agree.
I do too. Okay, and everybody up here, we represent a lot of passionate people who have different viewpoints. And so I appreciate that you represent a lot of people with passionate viewpoints, and we all know how this works. So thank you for that explanation, and it's a tense bill. So
Indeed.
Carry on.
Thank you. So my comments that I prepared prior to that that diversion are just to thank you. I really want to offer my appreciation. This is really important to people. I think we can talk for a while, and we won't today, about the access shortage in our state. We have a physician shortage. It's hard for people to find care. Anything that this committee does to try to address administrative burden and allow providers to deliver the care to the patients is appreciated and deeply needed. I think it's important to know that when we talk about cost, for every $100 that the US government spends, or not government, but like the United States collectively spends on healthcare, $8.50 of that goes to the physicians and PAs, providers actually delivering the care. The rest of it is in the rest of this system. And so we talk about prior authorization as a financial tool to help reduce cost, but it falls on the shoulders of the providers who are delivering the care and have the expertise, training, and education to do that care the best. But the prior authorization burden falls on them in addition to all of the other duties and responsibilities that we're asking of them. I wanted to address a couple of specific sections in terms of timeline and turnaround. We've discussed this, I think, throughout the interim a couple of times. Our interest in compromising has been mentioned, and that is true. We had conversations in July after the Evanston hearing with the medical directors of Blue Cross Blue Shield, And it was compromised at that point that we could move from the 24 hours to 72 hours from urgent. But as you all know, compromise takes a little from everyone. And so part of that compromise was not just the 72 hours for non-urgent. It was also then 120 hours for non-urgent. So 72 hours for urgent, 120 hours for non-urgent, not right now it reads 24 hours for urgent and 5 business days for non-urgent. We would like consistency in the language. We do think that if we're going to use hours in one section, that it should be hours throughout. And that was the compromise. So we're willing to move from 24. There is precedent for 24. There are states who are adhering and complying with 24 and doing fine with that. We do, in the spirit of compromise, understand that our payers here are very uncomfortable and feel that that's not something that they can work with. And so in trying to be good partners, we're happy to move to 72 hours from urgent for urgent. But I think with that comes 120 hours for non-urgent. And they're packaged, they're together. That's how compromises work. That's what represents a little bit of give from both of these parties. The consultation prior to denial is really, really important. And I think the statement made earlier by Representative Penn, the language is really clear and does say, shall be given the opportunity. It doesn't say you will stalk and track down that doctor and ensure that you have the conversation prior to denial. These are people's lives. This is their healthcare. Sometimes they're in a deep state of fear and they're living in a place of unknown. And so if a physician has decided that something's really important, this longer delay or delay associated with prior authorization can be really, really scary. And so if a physician has made that determination in their medical expertise and judgment, and it's going to be denied, they do deserve the opportunity to at least say, we can talk with someone and give more context, give the background of the patient, give their unique medical history, whatever the situation might be. But it doesn't say you have to have the conversation. It says the opportunity to have the conversation must be offered. And we don't think that's unreasonable. And we would very much appreciate that remaining in the bill. And I think with that, I would just close by saying, you've heard some examples, and it doesn't matter the piece of legislation. You'll hear examples of outliers. And so I will never stand before you and say that of all of the physicians licensed in Wyoming, all of them are perfect and all of them make the very best decision every single time. I won't ever do that. What I will say is that 99% of our providers are doing the very best they can. They don't have nefarious intent. They're not trying to skirt rules. They're really just trying to survive and do what they believe was their calling, which is healing people. And so when you make decisions about legislation, remember that we can get in the weeds to try to mitigate any opportunity for a bad actor to find a loophole. But I think that globally, regardless of the policy in question, that won't get us to anywhere good. And so if we legislate assuming the best and assuming the good, knowing full well that if there's a bad actor, a loophole could be found, that there's risk in that, but there's more risk in creating policy to try to go after the very small percentage of bad actors, and in doing so, doing a great deal of harm to the majority who are good actors. And so I would just offer that in terms of if you hear physician stories of, I don't know what the example is, a dermatologist using Botox the way they shouldn't, or whatever it is. I won't tell you that that doesn't exist. That would be disingenuous. What I will tell you is it's not the majority. And then when we're setting policy and having these conversations, it's really important to know and think about how it will affect the majority. And with that, I'll stand for questions.
Questions? I mean, most all of our laws are based on a small number of people who do things they shouldn't. And that's why we have a very complex myriad of laws for a small amount of people. Representative Chadwick.
Thank you, Mr. Chairman. Ms. Bush, on the issue of 24 hours versus 120 hours versus 5 business days, wouldn't taking it to 120 hours potentially deprive potentially 2 days worth of, a weekend, that would take into effect a weekend if you did the 5 business days. I understand the 24 versus 120 or 72, whatever you end up with, but doesn't that potentially take away from the time frame?
Ms. Bush?
Mr. Chairman, I think what we intend, and I was probably not clear, so I apologize. Let's talk first just about urgent. So for urgent, right now, the bill before you has a 24-hour timeline. And it further states that if the 24-hour timeline is not met, the request is automatically approved. Okay. Insurance has said that's untenable. We really are uncomfortable. We can't move forward with that. And so as part of a compromise, we've said, okay, then instead of 24, change that number to 72 for urgent. And 72 has been our limit. So separate from that conversation. So urgent is 24 to 72. Yes, it's longer, to your point. It's a compromise that we're sympathetic to the burden that would create for our payers. And we're really trying to be good players. So separate from that, then you have non-urgent. Right now, the bill in front of you says 5 business days. And so I think it's important to know that 5 business days can be as long as 2 weeks in some situations if you have holidays, and where it lands, when the request is made, if it's coming into a weekend and then Monday's a holiday, right? Like you all of a sudden have a much longer time period than just 5 days. And so our request has been, let's move away from 5 business days and go and keep it consistent in statute. So it's hours throughout, and say then it's 120 hours for non-urgent requests, meaning it doesn't matter if it's a holiday, it doesn't matter if it's Saturday. It's 120 hours. That's the expectation. Everybody knows it. It's hours, which is consistent. And so that, I don't know if that is, am I helping? Your face says I'm not helping.
Representative Chadwick.
Thank you, Mr. Chairman. I think you got there, but yeah, the holidays, I can see that being a problem. Yeah, I understood most of your rhetoric going into that. But I see the loss of time to get this done. And, quite often the carriers just simply aren't doing business on those days.
Mr. Chairman, Representative Chadwick, you're correct. I mean, in a utopia that physicians create, there isn't prior authorization, right? And so it's all a delay of some kind. They don't want to wait any amount of hours. That's not reality. And prior authorization has a utility. It has a purpose. And we're not here to tell you that it should go away completely, even though I do believe that it is like the utopia, that it doesn't exist. We're living in a landscape where it has a purpose. In good faith, we want to be good players. We want to compromise, and that's how we got to this delay. I hear what you're saying, in that it's a delay and it's hours, and we agree. So yes, and we're trying to do right. And so if prior authorization is going to persist, which it will, we'd like the timeline to be consistent. We would like it to be hours, not one section's days if it's a certain procedure, and this one's hours if it's this different kind of procedure. Let's be clear. Let's be transparent. Just because other states have it 5 days and 72 hours doesn't mean it's right. It just means that other mistakes did it wrong. And so let's do it right.
All right, other questions for Ms. Bush? She's probably not going anywhere for a second till the hospitals. I'm assuming you're also testifying. Mr. Hannes, welcome.
Good morning, everybody. Josh Hannes with the Wyoming Hospital Association. So just want to make a few sort of broad points about the current environment, along with some specifics about the bill. Obviously, we asked for this to come forward, and we support the pieces that have been included in the draft before you. And we have participated in several discussions with different insurance providers and their representatives, and we're far apart. And I think you heard from Blue Cross Blue Shield that that's just part of the inherent tension in these conversations. But if I could, I'd like to, just from our perspective, offer, and hopefully you'll consider this as well, as, you know, what is the role of insurance? And what we would say is that the role of insurance is to simply pay healthcare bills, full stop. The treatment decisions and care plans that are created should be between a patient and a doctor. And currently, and as you've already heard, that insurance creates and places a ton of burden on providers to jump through hoops to deliver the care that they think is best for patients. And we think that that power dynamic needs to change. So currently, insurance companies can deny claims right through prior authorization. They can deny coverage. If you don't pay premiums, you don't get insurance. Conversely, in a hospital situation, everybody who walks into our facilities gets treated regardless of their ability to pay. If they don't have insurance, they can't pay, they don't, and we eat it. And that comes out to about $120 million a year across the state. We're a significant part of the social safety net, and we're proud to do it. But this additional work adds to that burden, and it makes it very difficult for us to deliver promises to our community, to care for people that maybe don't have money or insurance coverage. Insurance coverage is a great thing, but we think there's things in it that need to change. I would ask you to consider also, when they talk about managing cost, that's a worthy goal if you believe that the money that you pay in premiums, so their revenue is premiums, and what they don't spend is profit. And they do a splendid job of maintaining that. You have insurance companies, small ones, who post tens of millions of dollars a year, up to larger companies that post billions a quarter. So whose cost are they managing? The argument that hospital charges drive cost is really puzzling, because we operate on thin to negative margins. So there's no money for us to give. We can give up services. So if you want to pull money out of our system, what we give back to you is less service and less access. So my point being, once again, excuse me, that the power dynamic should change and allow us to care for patients and communities in the best ways that we know how. I'd also point out that hospital costs over the years, over about the last decade, have risen about 2% year over year. Insurance premiums are about double that. Again, pointing out that the accusation that hospital charges drive cost really doesn't hold much water. And then finally, what I would say is that if prior authorization is burdensome, this bill creates bottlenecks, do less prior authorizations. I mean, I'm not trying to be flippant, but that's the solution. We have not shown, or have they offered, an explanation or evidence of the value this process creates and how it drives down cost, other than just not paying claims, or how it improves patient care. So with that, I'd stand for questions, and certainly Eric has other points.
Questions right now for the Hospital Association? Mr. Boley, do you also have some comments as well? And then maybe we'll just see if there's any comments for the three of you.
Thank you, Mr. Chairman, committee members, Eric Boley with Wyoming Hospital Association, and I won't belabor this point. However, the reason this bill is before you is because this is one of the biggest issues that our members face. We represent 28 hospitals. Those hospitals employ a tremendous amount of physicians, physical therapists, X-ray, lab, all of which are required to do pre-authorization. And I think it was great that you were able to tour a hospital yesterday, a brand new hospital, who's been open for only a few months, and they're already in the middle of this prior authorization issue, and they've had to add staff to be able to get their bills paid. I think that one of my favorite books is The Art of the Deal. And we have tried to be collaborative in our approach to this. We have involved the stakeholders, and we didn't pull any punches, but we didn't hide the fact that we were very open that we were going to bring this as a topic. And I think that we're in a pretty good place right now. No one's winning 100%. We do have compromise in here, and we've offered compromise. We met with Blue Cross Blue Shield. And the timeline for these pre-authorizations seems to be a problem. So in our comments in July, we offered 72 hours, and it was 5 days or 120 hours. I don't care which way it goes. Not business days, but days. But in exchange for that, we wanted to keep the peer-to-peer, before there's a denial. We wanted to give them the time and make sure that their physician could talk to our provider and make sure that the denial really should take place. I'm with Sheila and with Josh on this, though. At what point did the insurance companies start prescribing and treating? They shouldn't be doing that. That's why we have trained professionals, and they're being questioned on almost everything they need to do. They have to jump through hoops to get those paid. I listened to Senator Baldwin talk about changes in pharmaceuticals. That's step therapy. It's a great example of how we drive costs down and how we try other things. And actually, it's been shown that step therapy really doesn't work. A lot of times we end up going through step therapy, and then we end up doing whatever needed to be done after the fact, and we delayed care to these patients. We obviously have issues, and we're concerned about payment. More importantly, we're concerned about the patient experience and getting patient care as quickly as possible and taking care of those patients. One of the things that this bill has in it that I think is really super important is it has a data reporting requirement. We don't really know what's going on in our state with our insurance companies. We cannot get good statistics on how many denials take place, why they're denied. So I think that's a really very important part of this bill, is that we're able to get that data so that if we need to make changes, we can do it. And so I really think that that's important. The administrative burden. So I just want to talk about this. Hospitals are the most highly regulated industry in the country. I think FAA and banks are probably close, but we continue to add costs to the system. Mr. Mincy talked about the staff that they've added. They've got RNs that are spending 75% of their time on issues like this. And we're in the middle of a staffing shortage right now where we can't get enough RNs. We can't get enough LPNs. They're spending time doing that instead of caring for patients. And there's really no reason for that. I think finally the gold carding issue, I think it's super important. Why not remove administrative burden and get rules and regulations out of the way? We have great providers in this state that are doing the very best they can. Why don't we remove those barriers? This is such a big issue, though, that the federal government is looking at it. We talked about this early on. So Medicare Advantage plans, which we talked about yesterday while we were at the new hospital. Medicare Advantage plans are taken care of by Cigna. And there's actually lawsuits going on. There's all kinds of things going on nationally because one of the things they do automatically is they deny those claims. And then they have to jump through hoops. Our providers have to jump through hoops to get those denials reconsidered, and then 80% of those are overturned and they're paid after you jump through those hoops. Why do we need to do that? Mr. Spencer will tell you that this isn't done to contain costs, and maybe for Mountain Health that's not the case, but as a principle, as a whole, it is what is used by insurance companies to slow down the payment of claims or to not pay them at all. So I think this is a very common sense approach. I think it's well thought out. I think we've done a lot of good work on this, and we're happy to make the concessions that we've talked about as far as timeline. I think overall we have a very good product that we have all of us have worked on, and we've come up with what I think is a very good solution in the state of Wyoming. The last thing, though, that I would say, and I'm concerned, and in all honesty, this only captures a couple of our insurance companies in the state. We have other plans in our state that won't be affected by this. But when I take a look at the state employee plan, there's 35,000 covered lives. It's a self-insured plan, so it's overseen in a different manner. But I do believe that we should find a way to pull 35,000 covered lives into this legislation so that we can streamline the process and take care of our state employees that have health insurance through the state plan and expedite the care that they receive. With that, I'd answer any questions, and thank you all for your work on this.
Questions from the committee? Representative Dockstader.
To our three professionals at the table now. Would you consider taking prior authorization 24 LSO 68, working draft 7, and having it approved just as is? Or would you want the state compensation part sorted out first? All three of you, please.
Okay, go ahead.
Mr. Chairman, Senator Doxdater, I'm actually happy with the product we have here in front of us.
Thank you.
Mr. Chairman, Senator Doxdater, I'm happy also. I appreciate the work. I do want to be very genuine in the compromise that was constructed on the timeline. I think if we walk away without addressing some of those concerns, I will personally probably have not done my job as well as I could have. And so I think that's important. But I'm happy. I don't disagree with Mr. Boley's interest and sentiment around the state plan and those 35,000 lives. I don't know that you can pull it in today. I also don't know how you pull it in today. I think it's good to be on the record that that's a significant piece of our population. And they are under the state plan. So they are under the purview of the state legislature. But if you don't address that today in this bill, we are happy and we appreciate this work and we think it's a good product.
Thank you.
Mr. Chairman, Senator Doxdater, clearly, I agree with Eric. I think it's a practical matter, the state employees plan and trying to move that plan underneath this legislation would need to be done in a separate either bill or rulemaking anyway. So we're happy to move forward with this as is, and we can work on the other issues separately.
Thank you. Thank you, Mr. Chairman.
Representative Penn.
Thank you, Mr. Chairman. One thing that I just wanted to run past you, when I was looking through, again, when we went from the model legislation, there was a definition on. So look at page 5, definitions of medically necessary healthcare services. Initially, there was a definition in that model legislation that we were going with, and it was an LSO suggestion that we go with the what is in statute. And we kind of made that decision to go. My question is, would you be agreeable to going back to the original definition, which reads that medically necessary healthcare services means healthcare services that a reasonable physician would provide to a patient for the purpose of preventing, diagnosing, or treating an illness, injury, disease, or symptoms in a manner that is in accordance with generally accepted standards of medical practice, clinically appropriate in terms of type, frequency, extent, site, and duration. And then 3, not primarily for the economic benefit of health plans. Does that cause you any angst to just go back to that original, a little more basic definition?
Thoughts on the fly? And you can certainly think about it. We're going to be talking about this bill for another half an hour at least. But Ms. Bush?
Mr. Chairman, Representative Penn, the model legislation was provided by the American Medical Association. And so obviously we were comfortable with that at the time and didn't ask for that to be changed. That said, I don't remember exactly what the conversations were involving the change. And so because I can't think of those right now, and I might not be able to articulate how the change happened, I don't want to make a statement that I will later regret. So I don't know, but I think we were fine with either, and our members haven't had a problem with this one either.
Mr. Chairman, Representative Penn, if I remember right, it's part of compromise, and I think it was also we were trying to have statutes match up with the same definitions. I think we're fine either way, but and going back to Senator Doxdater's question, we do like the bill the way it is, but we're also willing to compromise on the timeline as long as we keep the peer-to-peer intact and make that available for our members and for the insurance companies to be able to comply with.
Okay. Any other questions right now? Representative Clausen.
Thank you, Mr. Chairman. Question to any of you. Page 6, there's line 33. It starts talking about medications for opioids use disorder. With the working task group, do you guys remember how that, can you give us some insight on how that got added into this bill? The history behind that?
And I know Blue Cross has made a recommendation to remove it as well. And maybe LSO could, if they were, anybody remembers how their opioid stuff came in? Mr. Hannes, do you need some time to think about it?
So, Mr. Chairman, Representative Clauston, are you referring just to the definition on page 6? Sorry.
Well, not maybe so much the definition, but why this is specifically included into the prior authorization piece. My fear here is that over time, things are going to change in medicine. Medications used for opioid disorder will change. I'm just not sure how this got added in, if we need to be this specific in this bill.
Ms. Johnson knows, so we'll turn it over to her for a second.
Mr. Chairman, Representative Klauston, it was actually part of the model language. That's how it ended up in there.
Mr. Chairman, Representative Klauston, I believe that the intent and the motivation behind that inclusion is if someone is suffering from a substance use disorder and they present with an interest in receiving treatment or getting better or healing, you have to strike very quickly because there's so much involved and so many layers to addressing that particular condition in a timely fashion. So if a person has hit rock bottom, as we've sometimes, as laymen, we talk about someone hits rock bottom, or they've really come to a point where something significant has happened in their life that has motivated them, you want to have a care team be able to respond very quickly and live in that moment with the patient, not say, we understand you're at rock bottom today, except we're going to need to wait until next Thursday when your insurance plan decides it's okay for us to then treat you. Because next Thursday they may not be in that same space. And so I think that that's the general thinking behind. There are some of these, and I don't know, because again, page 6 is the definition, and I can't find on the fly where it is codified that it doesn't require prior authorization. But I think the intent is that's something that regardless of what the treatment is and regardless of what the advance is or thanks. So yeah, it just says no health insurer or contracted utilization review entity shall require prior authorization for the provision of medications for opioid use disorder. So I think it's broad enough that as that changes, to your point, and as medicine shifts or advances, I think that it still covers it because it's not prescriptive or specific. It just says that the treatment of substance use disorder and whatever medications associated with that treatment are not going to be subject to a prior authorization requirement.
Okay, we'll get you off the hot seats for now. Let's go about 9 more minutes till we take a break. Jamie, did you have anything on prior auth? You don't have to. You're good. Nursing, hey, Jason. I'm just not, yeah. It's not every day we see a telecommunications lobbyist on a prior auth bill, but welcome to Labor Health.
Thank you, Mr. Chairman, members of the committee, Jason Hendricks. Yes, I am in the telecommunications industry, broadband provider. We're a small provider, serve a number of areas of the state. Our concern with this bill is that we're on a self-funded plan through the association that we're part of. And so I guess as I read this bill, I don't think that there's an exemption here for self-funded plans. And I don't think that this is exempted anywhere else. So with that as a background, we'll kind of go with our concerns. So again, so we are part of NTCA. NTCA is an association of 850 or so rural broadband providers across the country. Of that, there's a subset that are part of the group health plan of NTCA. And for us specifically, since each plan has to be state specific, we are the only provider in Wyoming that's part of that plan for NTCA. So our concerns with anything that would happen here that would cause insurance rates to go up would impact our ability to provide insurance to our employees and take away from our ability to actually provide broadband where it's needed, which is what our real goal is. So that's the main concern, and I think that generally there is an exemption for self-funded plans for state law, and so our recommendation would be that there be an exemption for self-funded plans in this bill. Two of the specific concerns that we have on the bill, and there's quite a bit, but two of the bigger ones are the gold plating specifically. I think that provides potentially some loopholes down the line, some bad incentives with it. That would be problematic. And then some of the provisions on timelines are inconsistent with what we do under ERISA for the time frame. So they're a bit tight. So there's the added requirements of what has to be done before a claim is denied, but then there are shorter timeframes, and so that pinch seems to be pretty problematic for our insurance. So that's basically it. I think that we do a good job of providing a good benefit to our employees. We pay a pretty high fixed percentage of what the premiums would be. They pay a smaller percentage. And so the way that this would work is if there's any additional costs directly because of what they have to do internally to comply with this law, or there's increased costs, say 10% of our employees all of a sudden, because this law is passed, there are now higher costs associated with our service. So our premium goes up because of the additional, it's potentially twice hitting us with cost increases. And the way the fixed percentage would work for what we provide for our insurance, there would be the direct impact on the employees of what they would have to pay for the difference. So kind of a different issue, different angle from what you guys are hearing, but hope that's clear what I'm saying. This isn't my normal issue. So thank you for the time and staying for any questions.
Okay. In committee, we're working on figuring out if we need some additional language or making sure that's covered. Questions, for Mr. Hendricks? Welcome, Senator Dockstader. Go ahead.
Sir, I remain optimistic that our insurance companies wouldn't raise our rates. Why are you concerned that they would raise our rates?
Mr. Chairman, Senator Dockstader, I mean, this is a self-funded plan. So, we don't have doctors, by we, I should clarify, I'm talking about the insurance company that we're part of. It's headquartered in North Dakota or North Carolina. There's not a doctor in each state. So if there's a small group of people, so if they have to do different compliance for Wyoming versus other states, that is a direct cost specific to Wyoming. And since we are the only company on that plan, that's a direct cost that would come right to us. And so, and then the other part of it was if there are additional medical procedures that are costly compared to current procedures. And that's really, from my understanding, lay understanding of medical necessity, it's medical necessity relative to what? Well, relative to the current procedures. So now if there's a higher cost procedure, say 10 times as much as something that's pretty comparable, that would seem to me like those employees that take advantage of that would cause more costs for our plan, which would then get passed on to us since we are the only entity.
Thank you, Mr. Chairman.
All right, thank you for being here.
Thank you.
It's always good to come to Saratoga. Anyone else in this side of the room? Tony, Melinda, welcome. Good. Welcome, pharmacists.
Mr. Chairman, committee members, thank you for having me here to speak on this today. I did want to address.
Intro, name,
Oh.
where you're from officially.
Melinda Carroll, representing the Wyoming Pharmacy Association, issues that had been brought up previously with the questions. Pharmacy does see prior authorizations quite a bit as well, and we do try and communicate with providers as soon as possible when we see those denials and really try and work with them to find what is best for the patients. And so that is one thing. As for increasing costs, prior authorization bills, I don't think that those costs have been borne out in any of the other states that have passed legislation such as this. And there are plenty of studies out there that actually have shown that while prior authorization requirements have reduced cost of the healthcare costs that they're targeted at, overall costs have not been reduced by it. And so it would be questionable to say that overall costs would increase if prior authorization legislation would be implemented in the state. So with that, I will go to my prepared statement. The Wyoming Pharmacy Association fully supports the efforts to implement prior authorization legislation in our state. We stand with the Wyoming Medical Society in recognizing that this is a critical patient access and care issue, and would encourage the committee to consider amendments the Medical Society has recommended. I have witnessed firsthand the challenges that prior authorizations requirements pose to both patients and healthcare providers. These requirements often lead to delays in patient care, administrative burdens, and increased healthcare costs. Having legislation that streamlines and standardizes the prior authorization process can ensure that patients receive timely access to medications and treatments they need, while reducing administrative burden on healthcare providers. We are dedicated to working towards reforms that prioritize patient well-being over insurer profits. It is instead essential to strike a balance between cost containment and ensuring timely and appropriate access to essential healthcare services and medications for all patients. And with that, I would stand for questions.
Questions for the Pharmacy Association? Seeing none. Okay. Board of Pharmacy have anything on that side of the room? Looking not. Mr. Hayes, welcome. And then after Ralph, we'll probably take a 10-minute break. I know we have 2 people, maybe 3 people online who also want to jump in on this. And then we'll try to get through all the public comment no later than 10:50. But with that, welcome, Mr. Hayes. Floor is yours.
Mr. Chairman, members of the committee, my name is Ralph Hayes. I'm the manager of the Employees and Officials Group Insurance Program. Since we had the issue come up, I thought I would step up here. Now, remember, this pre-authorization is really aimed at, of course, insurance companies, and it also includes third-party administrators. So while the state plan is not specifically mentioned in here, the fact that we utilize a third-party administrator automatically makes this an impact to the program. Now, I've been doing this for a long time, 41 years. And I'm in a unique position because we're a self-funded medical plan. I used to work on the insurance side. I see the bills, I know what happens. And as you know, pre-auth is in the place because of the bad players out there. And it's not necessarily bad players per se, but the burdens come out because there are certain players out there who, shall we say, want to maximize things. And I'm going to give you some examples. Let's take a look at orthopedics, right? We've got some orthopedic groups in this state. I've seen them. When a patient goes to them, the knife is always the answer. While another orthopedic group wants to go through step therapy. Let's try this first and this first and this first. So which one do you think we probably want to do the most pre-auth with? And orthopedic procedures can be very expensive, especially when you start getting into back fusion when it's not called for. It doesn't meet the medical criteria that's out there. A lot of cosmetic procedures try to get pushed through. Trust me, we see them. And pre-auth is an important tool to make sure we pay for what's in our contract, which is not for cosmetic procedures. So it has a place. I do want to address a little bit about the timelines for this. And we talked about the 72 hours versus the 24. And what was mentioned by the group was, of course, if you have one on Friday and you have 72 hours and you receive it, let's say what happens at, let's say 3:30 on Friday, and we have a holiday. So they just barely got it. Everybody's going home at 5 o'clock. So you're Saturday, Sunday, it's a Monday holiday, you're already out of compliance. And let's talk about the 120 hours. So you take away 48 hours for a weekend, same scenario, Monday holiday. That leaves 1 day for a non-urgent pre-auth. Now, I got to tell you, most of the non-urgent pre-auths aren't something that's going to be scheduled the next day. Those things are scheduled out much farther down the road to get taken care of. I can't even get to see my doctor in generally 1-2 weeks trying to make an appointment. So I do have a little bit difficulty understanding why we need 120 hour for non-urgent pre-authorizations. And that's from a standpoint of a plan administrator on a self-funded plan. So the timeframes don't necessarily make up. I do agree that pre-auth can be streamlined. I think there's been discussions on both sides. I'm kind of in the middle of this one. I agree with some with the medical society. I agree some with the insurance companies, but we are impacted by both of them. But the timeline issue, I guess I do see 140 hours, 5 days, the same issue that we talked about for delaying that care for the timeframes with a holiday gives the insurance companies virtually no time when maybe they should be dealing with the urgent one that needs a more immediate decision. How do you prioritize that on a Tuesday when you only have roughly 7 hours to get that completed because of the time frame that was submitted? And that's the only question, comments that I have on this particular one. I stand for any questions that you might have.
Questions for EGI? Representative Clouston.
Thank you, Mr. Chairman. Thank you, Mr. Hayes, for being here. So in your opinion, the way this is written now, the state employee plan would be included in this law?
Mr. Chairman, members of the committee, yes, because we utilize an insurance company for a third-party administrator. In this case happens to be Cigna, but it wouldn't matter who we would utilize, whether it be United Healthcare, Blue Cross Blue Shield, we would be impacted by this.
All right, not seeing anything else. Anybody can't wait 10 minutes? Then let's take a 10-minute break. We'll finish up public comment online, the two other people, and then we'll try to get something hammered out of here pretty quick. So let's say 8-minute break. That means 10:45. All right, committee, as we settle back in from our 7-minute, 13-minute break. We have a couple of people online who want to testify. First up, we're going to have Ms. Tebbit. Carly, welcome to Labor Health. The floor is yours.
Thank you. Good morning. Thank you, co-chairmen and members of the committee. I really appreciate the opportunity to provide comments to you this morning. I really appreciate the opportunity. Thank you for letting me do it remotely. I really appreciate it. My name is Carly Tebbit. I'm the Regional Director for America's Health Insurance Plans. AHIP is the national association that represents health insurance providers. And just wanted to share some quick comments. I know you're trying to get through public comments quickly, but we really appreciate the sponsors' willingness to work with us on the bill, appreciate the changes that have been made thus far. AHIP does have two key significant concerns. One is the timeline around urgent services, and appreciate the comments from the Medical Society about their willingness to move to 72 hours. AHIP would also make that request for that change. So really appreciate the dialogue on that and consideration of that change. Our other really significant concern with this legislation is section 5513 on the gold carding piece. This section creates a mandatory gold carding program. We have significant concerns with this provision. Prior authorizations only used in limited circumstances, and it's intended to help lower patients' out-of-pocket costs, protect patients from overuse or misuse and unnecessary treatments, and ensure that care is consistent with evidence-based guidelines. There is a significant amount of waste and unnecessary treatments in our system, and this is supported by academic research. And unnecessary treatments can be associated with adverse events. And so we do have a lot of concerns that this provision is going to create significant patient safety concerns. The threshold for 80% of for a provider to receive a prior authorization exemption with an 80% threshold is extremely low. This means that 20% of the care could still be fraudulent or unnecessary, and it doesn't get that the necessary oversight to ensure that is appropriate and it's safe for the patient. I'd also like to note that this section in particular is based on a law that passed in Texas in 2021. And that law had an effective date of January 1, 2022, but it is still in the initial stages of rulemaking. It has turned out to be required extensive rulemaking, and it's been an extremely heavy lift for the state to implement. And it's also estimated to be a significant cost driver for premiums in the fully insured marketplace in Texas. We have estimates that it's going to increase premiums by $1 billion annually. So we do have really strong concerns, as I said, with this section. Don't think it's appropriate to have a mandatory gold carding program implemented. Do think it will increase costs in Wyoming and will be counter to the goals that you're trying to solve with this legislation. So with that, I will wrap up and happy to answer any questions, but really appreciate the opportunity to provide comments this morning.
Certainly. Thanks for waiting. Questions for AHIP from the committee? I'm not seeing any, Carly, so thank you for being with us. Have a great rest of your Friday. Next up, Ms. Herman. Marguerite, welcome to Labor Health. Floor is yours.
Thank you, Mr. Chairman. Marguerite Herman, I'm speaking today as a consumer representative for the National Association of Insurance Commissioners, and the consumer reps have focused on this along with the AMA as an area that needs attention. And first, let me express great sadness at not being in Saratoga this morning. I'm stuck in Cheyenne. First of all, I would like to say that you don't need to demonize the insurance companies to really find, to define a need for better efficiency in the pre-authorization and really fix problems. I hope nobody goes there, and I haven't heard it so far today to a great extent. So I hope that's where we are. Some of these requirements in the bill, which I do support in general, is going to require some business changes by insurers in Wyoming. So it does impact, that they're like, for instance, staffing during holidays. time limit thing. So understanding that there's going to be some investment, there's going to be some cost on their part that needs to be recognized as part of this package. I will say that where I'm coming from is, how does this affect consumers? The enrollees is the term used in the statute. Otherwise, the insurance company call them ratepayers, but it's the same thing. It's the person who has really the greatest stake in that this system work and work well and be efficient, but also not cause well, we just heard from AHIP, you know, that there's waste, and I guess I'm not convinced of that. But that's the stake is health, it's cost, it's efficiency. And so I would like this process to include the consumers in all discussions going forward. It's been kind of the lost voice in this. There's a sense of it, got providers and insurers talking over the heads of the consumer. And really, the whole system exists for patients and consumers, enrollees, and we'll call them ratepayers if that's how you want to think of them. So to that end, I really appreciate the data gathering that required in this bill, so that we'll find out, instead of anecdotes, which are plentiful, as we all know, that find out is a pre-authorization working, and then we'll find out the changes made by the statutes and regulations. Is that working to make the system efficient, quick, responsive? I would, you know, it should say the number of denials, for what reason, the appeals. Do people know how to pursue appeals? Do they just give up and go away? Which we have some data that's what happens to consumers. They find the whole system just beyond their ability to deal with it, especially when they're sick. And so we have to make pre-authorization. If we're going to have it, we have to make it work. And is it saving money? What is the return on the investment of this process? Does it actually increase costs? Does it save money? And most of all, does it improve care? And as we all know, getting the right care is important, but getting it at the right time is just as important. Just real briefly, I will say the concerns of the consumers and consumer groups is that the current system is cumbersome. It creates delay and poor health outcomes, or it can. There's a National Patient Advocate Foundation survey that 45% of respondents report delays in filling prescriptions because of pre-authorizations, step therapy, or quantity limits. The MA reports that physicians report burden of time and staff and delay because of pre-authorizations, which you heard amply this morning. And insurances complain about deficiencies in data reporting. Other major concerns, there's a wide variation and lack of information about what services require pre-authorizations. And this is sort of the transparency piece that I'm hoping that this statute really addresses, that it does increase the burden on the patient and provider. Again, the National Patient Advocate Foundation survey found 37% of respondents reported in the past year that they expected a recommended service to be covered, only to find out it was not part of their plan. So that's, you know, patient information. And what did they do? They coped by, they modified treatment. They only took half their dosage of a prescription. They went into debt. They skipped treatment. And they had no idea how to appeal. So I think appeals, denials, and the outcome of that has to be part of the data collection. And just real briefly, the things that I think are important to be achieved in this. Oh, I guess I'll just really briefly mention what Sheila Bush mentioned about the hours, the time lapse being counted in hours. Yes, there is going to be a financial consequence of that for the insurance companies, for the people reviewing the requests. But as a consumer, as a patient, you want to know that you're going to find out. And during the long holiday weekend, that you may have to wait several days for something that is not urgent in the eyes of some, but for you it is. And And certitude, to the extent you can get it, I think, is achieved by by counting down in hours, not in days. And again, there'll be consequences for staffing and how they do business, but the return, I think, to the consumer, it makes sense. So transparency is a big thing. So the coverage, first of all, and I know this isn't part of this bill, but coverage to the consumer, what requires pre-authorization, what is covered at all, what is covered, what requires pre-authorization, make it really plain to the person, the consumer who in fact is buying the plan, the ratepayer. Make it clear to the patient and provider. Notice, which I really appreciate in the bill, notice when things change, when coverage changes, when pre-authorization change, and then give them a chance to adjust to it. Also information on how to appeal, where to appeal, and how that is handled. I think that transparency piece is important because you find consumers at 37% who had no idea what was coming and didn't know how to deal with it. Eliminate unnecessary repetition of reviews and duplicative approvals. Efficiency and the online portal, which was discussed, that I think will increase clarity, completeness of the data, and quick response. And so that will help both the insurance and the provider and the consumer.
Any specific amendments?
Pardon me, I'm sorry.
Oh, do you have any specific amendments?
No, I'm saying these are features I appreciate in the bill that I think as you go forward, again, this is sort of from the consumer point of view, and I don't have any specific amendments. I know that's a way of saying, please wrap it up, and I will do so very quickly. Limiting retrospective denials, keep that in place. I would like if you in the bill, one amendment that I would suggest is that including the enrollee language in all, when you say notified provider, notify the provider and enrollee or consumer, however verbiage you want to put in there. I know there are mentions on page, or I would like to insert mentions on page 12, 14, and 17. Wherever that comes up, please include the consumer in the information, in the notice, and that sort of thing. I know that there's some dispute wanting to change the continuity of care, very important to the consumers, so that if you change insurers, there is a continuity of care for 3 months while things get sorted out, when things get clarified. And then obviously I don't think the consumer has any part of the gold card, the exemptions given to providers either in general or on certain services. So we don't really have anything to say about that part. But those things, that the transparency is extremely important, and including the rolling in all notifications, I would be asked that be inserted throughout the bill. And that is really the end of my comments at this point. Thank you.
Thank you. Questions from Ms. Herman? We will look to see if there is a place to add enrollees with the information to providers.
Thank you.
Okay, not seeing any questions, Marguerite. Have a great day in Cheyenne. So, anyone else online on the prior auth bill? I know 3 of you are waiting on white bagging and 2 of you are just hanging out if there are questions. And then Representative Sweeney, I think you're just hanging out. Other people who want to testify on this bill on the side of the room? Ms. Ranking, welcome. Representing the entire Department of Insurance today, I see.
No pressure, yeah. My name's Jill Ranking. I'm the Senior Health Policy Analyst for the Department of Insurance. First, let me extend an apology from Commissioner Root. He was unable to make it today, and Deputy Commissioner Howard had a previous engagement also, so you get me. The only thing that I'm really going to bring up, everything's been covered really well. Obviously, we all know it's a hot topic and a lot of states are looking at this. I think in the last year, 30 different states have been looking at some form of a prior auth bill. It's a big lift and it's an overall good purpose. There was a question earlier regarding the medical necessity verbiage and language that was in there and why it had been removed. That was one thing that the Department of Insurance had suggested to LSO, because we have a medical necessity definition underneath the medical necessity 2640-102. And we just thought it would cause confusion to have differing definitions. So that was our request on that part. Another thing that has kind of not been addressed because it doesn't deal with really the providers and the insurers is there is that component of reporting. And I did visit with 3 states, New Mexico, Texas, and West Virginia. And it was in regard to the reporting part of it and what issues they had had with it. The reporting from all 3 states, they said that that became a very big burden, receiving the reports on what prior auth was denied, why it was denied, et cetera. They said that it can also depend on how they're reporting it. Some of the states do their prior authorization based on CPT codes. And West Virginia actually does it based on the provider themselves. So it doesn't matter what services they've provided, but if that provider has met their criteria for gold carding, then they can do it with any service that they provide. So they said that it would depend a lot on how you were looking at that reporting. Let's see. Another thing was all 3 of the states, I believe, had to have a system developed for them in the Department of Insurance to track that data. In our bill, I'm not sure, or we're not sure who would be tracking that data. It does say that it's provided to us, but we don't know who would be handling the initial information for that. And then the other part that has been a big topic today is the pre-denial. The only request or thought that we had on that is within that denial, there's been a lot of discussion today that it's optional for the provider to respond back. The insurer shall reach out, but there are no timetables in there. And it's the one section of the bill that when you look at it, doesn't have timetables. And so I guess the question would be, if we have that in there, will you have, or should there be a time period for the provider to respond back to the insurer saying they don't want to, consult, or if the insurer doesn't hear back from them in a period of time, that it's automatically they proceed with what their decision is going to be. I think that's it. Oh, there was discussion also about this urgent review time period. The only thing that I would point out is in the Department of Insurance Rules, Chapter 63, Section 9, when it comes to expedited reviews within that section, which is medical necessity, there is also for urgent situations a 72-hour review. And I'm just throwing that out there for your information. So if there's any questions, I will answer them to the best of my ability.
Questions for the Department of Insurance, Representative Clouston.
Thank you, Mr. Chairman. Thank you for being here. Just curiosity, earlier this year, we had heard testimony between Sheridan, Cheyenne, and Gillette. They had 30 job openings trying to deal with prior authorization. So those weren't actual employees, those were openings.
Mm-hmm.
Do we have any idea of how much money our hospitals in Wyoming spend dealing with prior authorization? I won't go into all the other providers, but maybe just hospitals.
Chairman Zwanitzer, Representative Clouston. From my point of view, I do not know that information. It's probably something that the hospitals or the hospital associations could give you information on. I'm more than happy to reach out while we're continuing discussions here and see if I can get that information for you.
Other questions for the department? Seeing none, bless you. All right, thanks, Jim.
Thank
for being in Saratoga today. All right, any more public comment? Going once, going twice. All right, we'll close public comment. Committee, I will await a motion on the bill if anybody wants to bring one. Senator Hutchins is moving LSO 68 to be a 2024 committee bill. Is there a second?
Second.
Seconded by Baldwin. Amendments or discussion committee. I know we've been provided a lot today. I think there were 5 that I would like to talk about, but as a chair, I'm not supposed to be bringing many of them. Senator Dockstader.
Mr. Chairman,
Yep.
why don't we just move the bill and pass it without amendments? We heard requests for that today from those who work the front line.
You're calling for an immediate aye vote on the bill without discussion or
Correct.
amendments.
Yeah, I got a second to that amendment. if that-
And Senator Hutchins second that. LSO, that's can we call for an immediate vote on a bill and close discussion? I suppose that's in order if the committee votes in favor of it. Right? All right, committee, the motion is to make this a committee bill without amendments or further discussion. It would be a motion to close discussion, you're right, and that would just be a vote of hands, and then we would actually do a roll call vote on the motion at that point. So all in favor of closing discussion, please say aye. Opposed, say no. No. Okay, we'll close discussion on any of the amendments that we've spent 2.5 hours listening to today. With that, Katie, if you'd call the roll on making 24 LSO 68 a committee bill for the 2024 session.
Mr. Chairman, this is roll call for 24 LSO 0068, prior authorization regulations. Senator Barlow. Senator Bouchard. Senator Dockstader. Senator Hutchings.
Aye.
Representative Chadwick.
Aye.
Representative Klauston.
Aye.
Representative Hornock.
Aye.
Representative O'Hearn.
Aye.
Representative Penn.
Aye.
Representative Trujillo.
Aye.
Representative Ward.
Aye.
Representative Yin.
Aye.
Co-chairman Baldwin. Chairman Wanitzer. Are there any changes? I to excused.
All right, committee, I do think there are probably some necessary amendments to be put on that bill at some point before its final passage into law in Wyoming, but if it goes to the House or the Senate, hopefully we can spend a little more time in depth and maybe all the parties who do have some thoughts. I know the Board of Medicine spent some time with what I thought was a necessary amendment that we will save hopefully for the session, and we'll continue to work over the next couple months on this bill. With that, the next bill before us is LSO 25, version 6, provider administered medication regulations, commonly known as white bagging. Anna, can you just give us a kind of review of the bill and what this involves and where we're going?
Yes, Mr. Chairman, members of the committee, this is 24 LSO 25, physician administered medication regulations. This bill draft contains a purpose section and a definition section starting on page 1. And then starting on page 4, draft states that a health insurance issuer or pharmacy benefit manager shall not refuse to authorize, approve, or pay a participating provider for providing covered provider administered drugs and related services. Condition, deny, restrict, refuse to authorize or reduce payments for provider administered drugs when the administration of the drug is a medical necessity and the participating provider obtains the drug from a pharmacy that is not a participating provider in the health insurance issuer's network. All payments for provider administered drugs shall be at a rate set forth in the health insurance issuer's agreement with the participating provider or at the wholesale acquisition cost. And a health insurance issuer or PBM shall not require a covered person to pay an additional or increased fee to obtain the provider administered drug when provided by a participating provider. Nothing in this draft shall prohibit a health insurance issuer from refusing to authorize or approve a provider administered drug when it does not meet medical necessity criteria. The commission of any act prohibited by this draft shall be considered an unfair method of competition and an unfair practice or act. And any provision of a contract that is contrary to this draft shall be void and unenforceable in the state. 2655-104 was added during the working group that took place in August. So this is all new language that the committee hasn't necessarily seen before this meeting. So in 2655-104, brown bagging is prohibited starting on page 8. And then health insurance issuers may require that providers receive medication from a specialty pharmacy. And specialty pharmacies must give advanced tracking information for mailed medications. Pharmacies must use appropriate packaging and environmental safety controls to protect the medication. and pharmacies must have an on-call pharmacist or nurse available to answer questions. If a provider administered drug does not arrive at the scheduled time or arrives damaged or unstable, a facility may use its own stock of the drug and shall be reimbursed at the health insurance insurer's contracted rate. There is one conforming amendment, and then the Department of Insurance is given rulemaking authority on the top of page 8. And then there's a split effective date. And I would stand for any questions.
Questions for Ms. Johnson on the mechanics of the bill? Okay. Committee, just for your edification, Representative Klaus and I did have a working group with a lot of the members in this room on various sides of the bill to try to get to an agreement, or at least the working draft 6 you see before us today. And so we'd certainly be happy to answer any questions, or we'll interject, I think, as we go along on some of the major points that were brought up during that 3-hour working group meeting on the bill. With that, I don't know who wants to jump forward and go first. There are some amendments, maybe pharmacy. And then maybe we can do insurance next, Ms. Ranking. We'll do the order of operations of kind of state agencies, and then we can get into greater public comment. So with that, welcome. Floor is yours, Matt.
Thank you, Chairman Zwanitzer, members of the committee. My name is Matt Martineau. I'm the Executive Director for the Wyoming State Board of Pharmacy. The bill as it stands before you, there's some concerns that the board has with how it's currently constructed. The bill, as it is constructed, ends up mandating that white bagging be a service that be provided as outlined in the bill. That presents problems for delivering patient care and access to care, because it pretty much removes all other ways where these medications were previously being administered in hospital settings or clinics or places like that. The bill is also a little concerning because it doesn't distinguish between an inpatient and an outpatient setting when these drugs can be administered. The other piece that is a little concerning to the board is the new section 2655-104, which end up putting practice requirements for pharmacies that would be participating in this, that would meet the criteria of being a specialty pharmacy. But those practice requirements are located outside of the Practice Act. So we're concerned that there would be a lot of confusion and misunderstanding of what the requirements would be there. These additional requirements to shore up the supply, so to speak, and require medications to be obtained through this new supply chain, we believe would end up increasing costs for the patients as well as the different facilities in Wyoming, as well as ending up causing situations where facilities in Wyoming that were previously providing these things would be in a situation to where they would not have stock on hand to be able to use in the event that medications arrived damaged or incomplete or anything like that. The increased cost aspect would come because these specialty drugs don't always come as a final dosage form that could be administered to the patient. A lot of times they are going to be different components that need to be compounded together into what becomes the final dosage form. So the facilities would still need to maintain very expensive sterile compounding equipment and environments to be able to do those final steps and make sure that the final product is able to be administered to the patient. But like I say, the bill ends up creating a situation where hospitals won't have stock to cover mishaps along the way. It creates a situation to where excess stock is unclear what happens when the dose isn't right and whose medication that ultimately ends up becoming. There's also concern about the requirement on page 6 in subsection B, lines 7 through about 10, which requires the entities involved to be compliant with the Federal Drug Supply Chain and Security Act. The information that we've heard from industry across the board is that no one is going to be ready for this when it is supposed to go and become implemented in November of 23. So requiring full compliance with DSCSA would effectively strangle the drug supply because very few people would be able to comply with that. We currently don't have, as far as I am aware, we don't have pharmacies that have any sort of specialty pharmacy accreditation in Wyoming. So that would be a complicating factor in delivering care as well. We do have some of our hospitals that are JACO or Joint Commission accredited, and that's a very costly accreditation to obtain. Pharmacies that would end up seeking to obtain this specialty pharmacy accreditation would be looking at something like a $3,500 application fee to even be considered to be a specialty pharmacy, plus anywhere from $1,500 to $2,000 in costs for hiring consultants, and ultimately a minimum of $40,000 to $50,000 in maintaining that accreditation for a period of years. And that can vary depending on who ends up providing the accreditation to the pharmacy. So the accreditation piece is very costly to require different pharmacies to do, or to require our hospitals to have to obtain an additional accreditation that they don't have currently. With that, I'd be happy to answer any questions that you may have about the bill or about that. We did talk with Chairman Zwanitzer about some recommended changes.
We can certainly talk about that in the amendment section. Anybody have any questions for the Board of Pharmacy? Well, I have Matt up here right now. Okay, not seeing it this time. Thank you. You want to just settle anything? Ms. Ranking, anything on this bill? Okay. Jen. Whoever else wants to come up first. Ms. Roday. And we do have a couple people in the waiting room we'll bring in and call on next. But with that, Heather, welcome.
Morning, Mr. Chairman. Again, my name is Heather Roday and I'm from Blue Cross Blue Shield of Wyoming. Wanted to visit a little bit about this bill today and reiterate that we want our members to receive safe and effective care with the highest quality and timeliness. And if there are cases where their safety requires infusions in a hospital, we support that and we pay for it. However, in situations where members can receive safe and effective care at a less expensive location, we want to be able to refer them to other places in the Wyoming healthcare system, which provide the same quality of care at a lower cost. And this bill would prevent us from doing that. However, if the committee's desire is to move ahead with some legislation, we have provided some suggested language in the past. Our language also included agreements that insurers would pay hospitals if there was a white bagged treatment that what I'll say was a fail, but with pricing restrictions that could prevent markups. This language was added to the original bill, but not actually in the way that we had envisioned it. Therefore, we have concerns about the current language, and we actually interpret the language a little bit different than what we've heard before. It appears to us that at the front of the bill, it actually bans white bagging and the ability to seek cost-effective venues for our members. And then at the back of the bill, it offers the guardrails that were suggested. I think that in either case, there is a conflict there that could be addressed. You have a lot of amendments, I know, that to the existing language that were proposed to provide some clarity, being very clear to allow white bagging with guardrails and not prohibit alternate sites of care. These amendments, while lengthy, were not meant to kill the bill, nor are they meant to have tricks in them. They are meant to work within the confines of the current bill, clarify language, and allow us to move ahead with tighter restrictions on white bagging without outright prohibitions on it or on guidance to lower cost sites of care. We actually don't understand why this legislation is needed because there are facilities who can actually prohibit white bagging on their own. And we've also heard that there are some facilities that would actually like to be able to do it so that they won't have to carry inventory. But so given the complexity of the bill and the need for more work to make it ready for prime time, we respectfully urge caution with moving ahead with this bill as it's written. we really have had conversations and we have tried to work through this bill with other stakeholders. We just don't think we're there yet. Those amendments will be discussed later. And we hope that this makes it clear. And thank you for the opportunity to comment on this today. Stand in for any questions.
Question for Blue Cross? Not seeing it right now, Heather. Thank you. Let's go online. Mr. Gee, if you can hear us, the floor is yours.
Good morning, Mr. Chairman, members of the committee. I'm Dr. Alan Gee. Thank you for this opportunity to offer thoughts regarding this proposed legislation. I appreciate the concerns for the delivery of quality healthcare in our state. And as a practicing neurologist in Wyoming for the past 23 years, I do have patients that are impacted by the availability and delivery of biological infusions for their neurologic disease. Given the challenges we face with the availability of care and the delivery of services, I have in this past year undertaken efforts to create more opportunities to deliver high quality biologic infusions to the citizens of our state by opening outpatient infusion centers in multiple communities. I have taken this undertaking at significant effort and expense. The purpose of these endeavors is to provide the high quality and low cost care available not only to my patients, but all patients receiving biological infusions. We have kept quality and the care of the services of the patients as our utmost priority. My concern is this legislation will impede the delivery of value-based care. Though the intent seems to be to improve the accessibility and availability of certain medications, it seems, as I read the legislation, and as it's written, it will increase the cost of infusions, decrease the access to infusions, and decrease the quality of care for patients. Some examples. In regards to the cost, most Part B medications have coinsurance, which is a percentage of the negotiated rates between the provider and the payer. Health systems have higher rates, and therefore patient experiences a higher cost to access these infusions through those facilities. In regards to the access, Wyoming citizens already have mechanisms for access to hospital infusion centers. Payers have the ability to grant care exceptions based on mobility, location, accessibility of infusion centers. These can be used to accommodate the patients. And quality. Most healthcare systems provide infusions in their facilities. And as we all know, hospitals are typically places where we go when we are sick. And so there is an increased risk of exposure to infections. And the patients that I'm concerned about and care for are immunocompromised just on the basis of the biologic infusions that we are offering them. Providing them an outpatient solution where they have a decreased risk of acquiring community-acquired infections can enhance the quality of their care. There are also the training we provide our nurses and nursing staff, infusion nurses for the specific biologics can enhance the experience they have in an outpatient infusion center for biologics. So my suggestions if this legislation proceeds would be to make sure we have modifications to enhance business competition, enhance transparency for the consumers, enhance the infusion availability and access, and most importantly, enhance quality of care rather than create legislative impediments to this access for care for our citizens. Thank you, Mr. Chairman, and I'll stand.
Thank you, Dr. Gee. So I just want to make sure I understand your testimony. You operate an infusion center clinic that patients can utilize your clinic or the hospital depending on that patient's choice right now. Is that a fair assessment?
It's a fair assessment, yes. I have infusion centers available in several communities throughout the state.
Okay, Representative Clouston, question.
Thank you, Mr. Chairman. Thank you, Dr. Gee, for being with us. Dr. Gee, can you describe the supply chain custody, making sure that those medications that you're giving to patients are handled appropriately and safely before you deliver them to your patients?
Go ahead.
Mr. Chairman, Representative Clouston. So I am partnered with a national pharmacy and national infusion company that is in charge of and manages that supply chain delivery. We use a specialty pharmacy that supplies the product. We track and secure the shipments and the deliveries through the parent company of Talus Infusions.
No follow-up. Any other questions? Not seeing any right now. Dr. Gee, thank you for being with us. We'll keep taking public comment and see where we end up here. Other public comment in the room, welcome, Ms. Mack. And Eugenia. Floor is yours when you get situated.
Hello. Good morning, Chair Zwanitzer and Baldwin and members of the committee. My name is Michelle Mack, and I'm a Senior Director at the Pharmaceutical Care Management Association, otherwise known as PCMA. We're the trade association for the pharmacy benefit managers. I just wanted to thank the committee and thank the working group members for all the work that we have put into this. I know that PCMA and the insurers and our members have done no less than, I think, 3 or 4 different versions of, language that, we've suggested and we've supplied. The last of which I sent to the chairs and various committee members, of which I do have the list of amendments, and I apologize that there are, I think there's like 49 or 54 of them. My numbering got off at the very end, but we went line by line. And I just, what Ms. Roday had indicated, it's not our intent to kill this bill. This is an emerging issue. It has passed in 6 states total so far. The first time that it passed was in Louisiana, this is what this model was based off of, which I believe was in 2020. So we are just getting in to see, what the effects are of this. We're happy, like I said, to work with everybody, but we just feel that this is, as you've heard previously, this is a very contentious and it's a very complicated issue. And that's why we have so many amendments, because we just want to get it right. I can talk. I don't know if you want me to go through, want us to go through all of the amendments. I don't think you want me to waste that time, but I think just a lot of them are, just correcting some things. And then just, putting some things into place that have been discussed previously.
Any kind of the major policy, I know some are kind of technical corrections and some wording changes, but any high level kind of policy issues you have with the current legislation would be great.
I would say first and foremost is the, relative to the covered benefits, the preservation of the insurer tools for use of in-network providers and pharmacies, which I've talked about, which is essentially freedom of choice. And we are saying that eliminates the provider networks and the any willing provider statute in Wyoming. And the other item is also where it, prohibits white bagging or bans it, and then also allows it. So, that is the 2 issues that I would bring to your attention.
Committee, you were given a list of those amendments. If anybody has any questions on any of them, or generally on what PCMA feels? Not seeing any currently. Mr. Hernandez, additional comments? Welcome, Eugenia.
Good morning. My name is Lucina Mendez Harper. I'm a pharmacist and I work with Prime Therapeutics. We are a pharmacy benefit manager owned by not-for-profit Blue Cross Blue Shield plans across the nation. Certainly appreciate all the effort that's been put into this legislation. This concept is pretty complicated. And again, do want to reiterate that the extent of the amendments was in response to LSO indicating the preference for us to bring amendments to this committee. Again, the intent from our perspective was to try and make the bill as better as most we could. But I do want to address a couple of things that were said. This bill doesn't mandate white bagging. What the intent is to allow it as an option, but then also to have guardrails around that practice so that if it occurs, there are guardrails specific to the safety issues that were raised. And that's what we've put in the bill. The other thing I want to just clarify and make sure that everyone understands is white bagging is the drug sourcing. So it's actually how are you getting the drug, the actual drug product. It's not putting it together and getting it ready for infusion and then administering it. It's not that process at all. It's actually what Dr. Gee just talked about, how he uses a specialty pharmacy to send him the actual drug product. He receives that, and then he does all of the putting it together into an infusion dosage form, and then administering that that medication. So I just want to make sure that there's a clear understanding. This is about the drug sourcing. It's not about compounding it and administering it. That would still occur at the clinical practice site, whether it be a hospital or a infusion center or private practice setting. Let's see. And then, one other thing. This bill I don't see anywhere in here where it prohibits hospitals from having medication on hand. So again, this bill it's a complicated concept. It's hard to understand, and certainly there's room for more discussion and clarification. But I think at this point, there's still a lot more work to do, and we would ask for that to continue.
Any questions from Ms. Harper? Representative Clausen.
Thank you, Mr. Chairman. Thank you for being here. You know, the goal of this was really the patient safety. And we all had concerns that we shared. We didn't want price gouging by anyone, right? But we want to make sure that these patients, who are all of our customers, are taken care of. So I appreciate your work on this. And the goal of this was never to completely ban white bagging, right? Just to make it safer for Wyoming. Where in the bill do you see that it bans white bagging?
I'm not sure Ms. Harper said it banned. I don't believe that was your testimony, but go ahead. There was some concern that it has incongruent thoughts in the first page from the last page, but go ahead, Ms. Harper.
So Chairman Zwanitzer and Representative Clausen, thank you for the question. It wasn't my statement, but I will respond to it. Page 5 says that a health insurer shall not refuse to authorize, approve, or pay a participating provider for providing covered provider administered drugs and related services to covered persons. So we interpreted that as a white bagging ban. Then later on in the bill, it talks about you can have white bagging, and there are some provisions some of the provisions were in there about, if there's a shipment malfunction and a way to access it locally if needed. And so that's really where that was one of the conflicting elements that we saw. There was also some conflicting language about whether you could have differential cost sharing based on where that site of care was performed. In one part of the bill, it said you could, and then another part of the bill, it said you couldn't. So again, our amendments we're trying to identify and fix the conflict, what we interpreted as conflicting provisions, but also reflecting what the discussions had been and what we understood to be a general agreement on what the intent was that we were trying to have.
No other questions? You finish your testimony?
Yes. Yes, thank you.
Thank you, Ken. Mr. Spencer, you're up. Come on down. Welcome back.
Good morning, Mr. Chairman, members of the committee. Bruce Spencer, representing Mountain Health Co-op. After my testimony in the last bill, nobody will talk to me, so maybe I can redeem myself now. So Mountain Health Co-op shares the concerns and agrees with the amendments that have been presented. We did have significant back and forth discussions on this bill with providers, and I greatly appreciate their input, and we're all trying hard to come up with solutions. We're just not quite there yet. I'm going to talk about one particular amendment that I was involved in because I was trying to solve a problem that was raised during the working group, and then we worked on it afterwards. And that is frankly Representative Clausen's experience where they had to go to an infusion center and the drug wasn't there. And so there's that. And sometimes when somebody's at a hospital or an infusion center, the provider, for very good reasons, says, well, I need to change the dosage on this specialty drug infusion. And in those two circumstances, we all agreed that it's completely appropriate for the hospital, it's going to be a hospital pharmacy generally, let's be honest, specialty pharmacy. It's completely appropriate for them to dispense that drug versus having the drug delivered from the national specialty pharmacy. And so we put in a provision that allowed for that. We're discussing it. It's in one of the amendments that you see. The concern from the insurance company side is, well, how much is that hospital going to charge us for that? Because what we have seen is 200% markups on specialty drugs. And just to put that into perspective for you, in one circumstance where my client couldn't do white bagging, the drug was $500,000, and with white bagging, it was $250,000. That's one person for the year. So multiply that out. These are big numbers we're talking about. So that's why the concern. So the concern was, all right, we'd like to have the medical provider be able to provide that drug in those circumstances so the patient isn't inconvenienced or put at risk, the dosage change. But what kind of cost containment can we agree on? And that's where we haven't come to agreement yet, right? We aren't, what our proposal was, well, that you meet the cost that our specialty pharmacy is charging us, right? And they've said, well, we have concerns about that. And truthfully, one of the questions was, well, would a hospital pharmacy potentially lose money? And the truthful answer is it's possible. And we haven't come up with a solution for that. And we'd all like to, we're still working on it. And no one's acting in bad faith. We just haven't gotten to a solution to that particular question yet. But you do see at least the amendment on allowing the hospital to prepare the drug and get it to the patient. And it does have our provision in it that says you meet the specialty pharmacy rate. Okay, so I'm going to go, I wanted to just discuss that particular amendment with you so you understood the background and that we want to solve that problem. I think that you heard the pharmacy board express concern about the provisions on page 9 and thereafter, which is that if a health insurer is going to require the specialty pharmacy to deliver that drug to the infusion center directly, that specialty pharmacy has to comply with certain things. I think in all good faith that those aren't really regulatory restrictions on pharmacies. It's a regulatory restriction on an insurer to make sure the pharmacy can do this stuff. And we are told that our national specialty pharmacies can do this stuff. Can the local community pharmacy do it? Probably not. But I'm not sure the local community pharmacy wants to stock those incredibly expensive specialty drugs either. I could be wrong, but that's, I mean, like I said, it's a $500,000 drug. That's a lot of money to be carrying for stock, right? So the point there is we need some more engagement, right? We need some more engagement with the pharmacy board so they're comfortable or we're comfortable, and we don't want to pass a bill that causes problems within pharmacy regulation when really what we're trying to regulate is insurer practice, right? So I think there's more engagement needed there. There's more engagement needed overall. From a public policy standpoint, okay, I want to just give you a few numbers. Mountain Health Co-op has 60,000 members. Well, the Wyoming portion of that is 18,000, so about 30%. Wyoming accounts for more than half of the premium that Mountain Health Co-op collects every year. You already know your insurance rates are high. There's just another example of it. Bills that stray outside of the norm or are different or costly simply raise that because we pass that on to the ratepayer, right? And from a public policy perspective, that's unfortunately the charge that you are all charged with. You can say that there's a significant need in white bagging and direct delivery of specialty medicines, and that we want to restrict the ability of insurance companies to incentivize use of lower cost infusion centers. Okay. which is going to raise rates. Or you can say we're more concerned about keeping rates stable and we don't want to do this, or we'll change some things in the bill to make it so it's not quite as bad and it doesn't restrict the competition that insurance companies want to see, because we want to be able to incentivize and educate our members about safe and effective alternatives to sites of care. So I understand that's a tough public policy position. I get it, right? That's why you get paid the big bucks, right? We all know you're making big bucks, but there it is. I mean, that from our standpoint, there it is. Am I leaving? Is my company leaving the state if the bill passes? Absolutely not. We're committed to Wyoming and we're staying. But costs get passed through. Thank you, Mr. Chairman. Happy to answer questions.
Thank you, Mr. Spencer. Questions? Representative Clouston.
Thank you, Mr. Chairman. Thank you, Mr. Spencer. Page 6, you kind of sort of refer to this, lines 9 through 12. So it talks about the health insurance issuers agreement with the participating provider. And if no rate is established in the agreement at the wholesale acquisition cost. Who determines the wholesale acquisition cost if Mountain Health and one of our hospitals cannot come to an agreement on a price?
Mr. Chairman, Representative. Well, the wholesale acquisition cost is kind of a term of art in the community, but I think you raise an excellent question, right? Is wholesale acquisition cost the invoice from the wholesaler to the pharmacy? Does that give you a true picture of their acquisition cost? It's an easy number to get, right? Show us the invoice, but I'm going to submit to you that it does not represent an accurate picture of their acquisition cost, because on the back end, not shown on that invoice, are discounts and rebates and monies that the pharmacies get from their wholesaler for doing drugs. And if that particular pharmacy happens to be in a qualified facility and it's a federal program called 340B, if they're a 340B qualified facility, in addition to all of those things on the back end, they also get a substantially reduced price from the manufacturer for those drugs, none of which are shown on that invoice from the wholesaler to the provider, to the pharmacy. So it's there, and yes, that's the invoice, but I don't believe it's an accurate reflection of the true cost. And it is a complicated cost to figure it out. It's very complicated.
Thank you, Mr. Chairman. You know, the other cost would be shipping costs, cost to a facility as far as getting it from where it's shipping to the pharmacy, compounding the medicine. So there's other costs in there. So again, one of my concerns is, you know, I want the patient to get the medicine when needed. And, you know, I don't want to see a $250,000 medicine being charged $500,000 for. So I guess this is one of my sticky points that I'd like to see some resolution on.
Mr. Chairman, Representative Clausen, so would we. Some of those costs, you know, if you're the shipping, the insurer pays for all those internal costs with the specialty pharmacy, right? We're paying that specialty pharmacy to ship to the infusion center or the hospital. We're covering all those costs. Okay, those are all part of the package. But you raise an excellent point, and that is, you know, that medicine has to be compounded and then administered. And absolutely, providers deserve to be paid for that. And we should be negotiating appropriate rates with them to do that and have no problems doing so. We're paying for it today, but if it's not the appropriate rate, it certainly can be negotiated.
Okay, other questions? Seeing none.
Thank you,
Spencer. Other people wish to comment on this bill? Well, you both can come up and sit together. There's 4 chairs. Melinda, and you can take one. Josh, take one. We'll let Melinda go first because she's closer to the table. Welcome. Floor is yours.
Chairman, committee members, Melinda Carroll with the Wyoming Pharmacy Association. I'm also a practicing pharmacist, and I am very familiar with several issues that have been brought up. So on the cost, the wholesale acquisition cost, I would like to address saying that showing the invoice doesn't show our actual cost. I can tell you on brand name medications and specialty medications, rebates don't happen, what Mr. Spencer was referring to. Usually when you get rebates through your wholesale drug supplier, it is because of bulk purchases, and that is bulk purchases on generic medications. So let's be very clear on the cost of the medication. I am not going to speak to the hospital side of that. The 340B is absolutely something that reduces cost. And if they are a 340B entity, they should be charging 340B prices. I'm sure that Josh can speak to that a little bit better than I can. To clarify that cost piece in there. The other thing that I would like to address is saying that this bill bans white bagging. With that statement on 5, it is not banning white bagging. It is making so it is not mandated, because many of these health plans are mandating that white bagging occurs. And so that is taking away patient choice. It is taking away patient access to care. It is further narrowing networks. And that's what we're concerned about, are those things. And so I would argue that this does not ban the practice. It says that they shall not mandate it in their contracts. Also, I would like to address saying that our community pharmacies are not able to provide these services. I wholeheartedly believe that our community pharmacies can provide these services, and there are several in Wyoming that do follow sterile compounding. They are inspected by our Board of Pharmacy and inspected to standards of USP 797, USP 800. And there are pharmacies in the state that have additional certifications to compound specialty medications and do contract with health provider or health insurance providers to deliver those medications to people's homes for home infusion, and can provide them to infusion centers. So having further regulations on pharmacies in this bill absolutely regulates Wyoming pharmacies, because Wyoming pharmacies are providing these services. And so this is an inappropriate place to have that section on regulating pharmacy. That would go in the Pharmacy Practice Act. And we are opposed to having that in here at all. And so that would be the entirety of section, I believe it is 2654, 155. The whole last section, pages 9, 10, and basically all of 11. So I would ask that the committee take that and strike that. I believe.
Can you say it one more time for that?
Yes, I will absolutely say that in just 1 second, because I want to make sure I get it right for you guys. (2655-104). Yes,
Go ahead.
absolutely. The Pharmacy Association also would like to bring up the concerns that were stated by the Board of Pharmacy with having the language in it requiring the compliance with the Drug Supplies Chain Security Act, DSCSA. The FDA has already pushed this go live date back a full year to November of 24. And based on industry comment, it could be a moving date that we're looking at. So having this language in the bill could potentially allow health insurance plans to not comply with subsection A of that particular section. Let me find you that. It's page 5, subsection A. That basically is saying that they shall not mandate this. They could call into question the drug viability and say that it is not viable, and therefore they don't have to comply with this, and they can use their own specialty pharmacy to do it. And so it would be a loophole, and I would highly recommend taking that language out to prevent that loophole from being there. With that, I would also recommend that that you reject the proposed language for medical necessity. That is page 7, line 17 through 27. Those recommended revisions to medical necessity. So medical necessity should never include location of service. And that is what they're trying to include in that. If the medication is medically necessary, it will remain that way, whether the patient receives the medication at an infusion center or at a hospital. I would advise the committee to not accept that alternative language in the staff comment. If there needs to be further clarification on that, I have heard some statements on, that language not being entirely clear. There are alternate sources of that language. There is model legislation that the American Society of Health System Pharmacists or Pharmacy has that is been used in a couple different states as well. So as I discussed, page 9, I would strike page 9, page 10, page 11, lines 1 and 2. So mandating strict qualifications to dispense specialty medications, while well-intentioned, can have unintended consequences and hinder patient access to essential treatments. The qualification requirements will limit the number of pharmacies and healthcare professionals who can dispense specialty medications. This limitation in turn reduces the availability to these crucial treatments for patients, particularly in underserved and rural areas. Patients may face longer wait times and have to travel great distances to access care. In a state such as Wyoming, a much larger percentage of our population will be affected by this. And as I have already argued, the Wyoming Board of Pharmacy is the proper government entity to draft rules and regulations for pharmacy. Language that is proposed in this draft quite clearly regulates pharmacy and places the regulation with the Department of Insurance, which, as a professional that has to follow the Practice Act, I would draw issue with, and I would imagine that something of this effect would potentially be challenged. Statutes and regulations are meant to ensure fair and consistent standards that protect the public interest, allowing those to be regulated, being drafted by those that it is regulating. In this instance, health insurers can sometimes be a conflict of interest. And in this particular instance, I believe it is. I believe that these particular restrictions would encourage use of specialty mail order pharmacies that are oftentimes owned by the health insurers themselves, keeping that profit stream in their wheelhouse. This is also being investigated, as we all know, federally. The FTC is investigating. There are several bills federally that are going through right now that is looking at this very particular issue, as well as other issues in regards to these industry practices. With that, I will stand for questions.
Questions for the Pharmacy Association? It must have been amazing. No questions for you. Thank you very much. Welcome, Mr. Hannes.
Thank you, Mr. Chairman, members of the committee. Josh Hannes with the Wyoming Hospital Association. So if I could go back and provide just a little context for the committee. So we came during the interim and asked for this topic to be considered. And then we brought model legislation out of Louisiana, which, to oversimplify, would eliminate the practice of white bagging. And this committee assigned a working group to look at that. And Mr. Chairman, you were part of that, Representative Costin. Representatives from the various insurance companies participated in in-person meetings, back and forth emails, phone calls. And I would like to say that I do appreciate the willingness to work on these issues with the people who've testified previously on this. I do think it has been cooperative. I think people have come to the table in good faith to talk about this. And as you noticed, obviously, from the dozens of amendments from insurance, some of which I frankly agree with, we've maybe confused the issue a little bit and caused some unnecessary complication. And I have to own some of that, right? When I participate in things, I'm known to screw it up. So let's see if we can't get back on track a little bit. But what I would like to do is talk a little bit about our concerns and then maybe offer a way to simplify what we're trying to accomplish. So our concerns, as you've heard from others, have to do with when a hospital anyway, I'll only speak for hospitals, when they procure drugs, specialty or otherwise, they come through a normal process. We have insight into that supply chain from when it leaves the manufacturer's facility to when it arrives in ours. We have a number of regulations on how we manage that inventory, how we enter it into our electronic health records. It's often barcode scanned. Some of those processes are automated for efficiency's sake. When they come in a different way, if a white bag drug, that comes outside of our normal procurement process. We don't have insight into that supply chain and where it comes from. They're often not barcode scannable, so it requires manual entry into our electronic health record. They also have to be managed separately from the rest of our inventory because they're patient specific. As you've heard, I think Representative Closton brought this up, and perhaps Bruce as well, is that it could come in a dosage that was appropriate at one visit, but when the patient comes back to have it administered, another dosage would be appropriate for whatever reason, and then there can be delays in care. We also wouldn't have necessarily a lot of confidence in if it needs to be temperature controlled. So in transport, was it managed? Was it handled and maintained in a way that by the time it gets to us and is ready to go to the patient, that it's safe to use? And so what you heard at your last committee meeting from our pharmacists was that a lot of that medication gets spoiled and wasted and sits around. You can't use it. So those are our concerns on sort of the administrative side and the patient safety side. We do have, as it relates to what we'll call patient steering, is we believe in patients should have options to go to an appropriate setting of care. And when we had our working group meeting, I think there was some lack of understanding about, these other places may be lower cost, but what is their level of safety and how is that monitored? I'm not casting dispersions on any other provider. I'm not saying they're unsafe, but some insight into how that's managed and monitored and understanding so that we can make public policy decisions about where appropriate settings of care actually are. But I do want you to hear, I'm not saying insurance companies are sending people to unsafe providers. I'm not saying that. But it would be, they're not regulated the same way a hospital is, for instance. So let's maybe talk about how we could simplify. And I haven't talked about this with the working group, but maybe offer for your consideration. I don't think it's necessarily a meet in the middle excuse me one second. Let me back up. The rate, when we're talking about rates for payment, those are negotiated rates. Insurance companies may think they're too high, that they're inflated. I mean, this is like we've talked about, there's some inherent tensions between payers and providers. But those rates are negotiated. They're not surprises. But that being said, is there a way that we could, like I said, simplify this process where we say in statute that an insurance company can, and Montana has attempted some of this language recently, that an insurance company can offer or request that the specialty drug be provided in this white bagging process. A facility could say yes, and then you proceed and move forward and the patient gets served. But if they say no, if the facility doesn't want to take on that risk, could we make it so that the hospital, in our case, serves the patient, they submit a bill that gets paid? Because right now, if they deny or do not accept white bagging drugs, they could deny the claim. And so there's some decisions to be made by the facility in those cases. So I realize that this is just coming now. It probably requires some conversation, but I offered that to you as another way to consider working on this issue. And with that, I'd stand for questions.
Questions for the Hospital Association? Representative Closton.
Thank you, Mr. Chairman. I guess same question, that I brought up previously is wholesale price. Is that a little bit of what you're referring to in these situations where you and an insurance company cannot have a negotiated price?
Mr. Chairman, Representative Closton. So we've spoke to our members about this issue specifically, and in the spirit of compromise, we would be okay in these cases talking about a way to say cap what the charge would be in a hospital setting. The concern there becomes, first of all, what is it? Right? You heard Mr. Spencer talk about their suggestions, which we can't accept. But where's the sweet spot? Our concern though becomes is that am I going to sit here in 2 years and talk about other drugs, other services being capped at a certain, percentage of Medicare or some other formula? Is the legislature interested in rate setting and getting involved in making statute that says what something should cost or what you should pay for it? So I hope that answers your question.
Other questions? Not Sydney. Thanks, Josh. Other questions from Melinda? We'll have her up. Nope. Okay, other people commenting. Let me double check online. Anyone else? Online. Seeing no hands raised. Oh, Ralph, you want to come up? Sure. Drove all the way to Saratoga, and I know you don't have many of these committee meetings left. So, because he's announced his retirement committee, not because he's moving to Florida or anything. Welcome.
Thank you, Mr. Chairman, for that introduction, an interesting one. My name is Ralph Hayes. I am the manager of the Employees and Officials Group Insurance Program, at least up until December 29th of this year. And yes, I have announced my retirement and after 22 years in this position. In this particular piece of legislation on the white bagging, I guess from my perspective, it does impact our program. So there is a fiscal impact because I do believe that this prevents steerage away from providers. And while I appreciate the hospital's position that those particular drugs are negotiated as far as their total package of reimbursement, quite frankly, the margins involved with that can be extreme. And not for all the small community hospitals, but the majority of our care is taking place in 3 facilities, Laramie, Cheyenne, and Casper. And quite frankly, every hospital in this state is a monopoly in that community. So negotiation can be tricky. And quite frankly, the insurers don't have a lot of leverage in that particular area. And part of the leverage they do for this negotiation is moving care where appropriate to in these infusion situations to an alternate site of care. If that goes away, which in the way I read this bill, it's unfair trade if you move that care somewhere else and the insurer is penalized. Then it stays with the hospital at, quite frankly, in a lot of cases, an exorbitant rate. And Blue Cross gave you an example, and I've seen examples myself. For example, some medications for anti-nausea after dealing with some cancer treatments, which is administered the next day. And the markup on that is like $18,000 over cost. So that's the kind of money we save every time those get moved to a different facility in there. So the fiscal impact of this piece of legislation first year would be $1.2 million. That's all I have. So if I stand for any questions, if you have
questions for you, Jack. Not saying any. Thank you much. All right, let me check the online community one more time. Mr. Meyer is on there. Hold on a second. Let's let him in. And then I suppose after that, we'll close public comment. And there is. Welcome, Mr. Meyer. Floor is yours. Matt, if you can hear us.
Sorry, there we go. Unmuted. Good afternoon, Mr. Chairman and members of the committee. I'll keep this kind of short. I don't have a lot to add to the discussion. I would just like to reiterate the comments that my associate Melinda Carroll made, and also the hospital association. You know, really, this bill is I guess from our intent and looking at it was not preventing the practices of white bagging, but just preventing the mandating of it. To reiterate, reimbursement rates are negotiated. They are set forth by insurers and organizations. And moving forward, we are a community pharmacy that does supply some of those specialty medications for our local addiction treatments buy and bill program. The comments that are made that if you know, white bagging is continued to be allowed and insurance is mandated, that hospitals or other providers could turn around and rebill those medications from stock if white bagging medications don't arrive in time. It's quite simple. We're not going to stock those medications if we're not able to routinely sell them. The comments regarding WAC and the acquisition costs on those specialty items and all the discounts that are behind those. Unfortunately, that's also not true. When it comes to specialty and brand name drugs, a lot of times those are set outside of those contracts. You might be talking about a 2% difference between WAC and what the invoice price is, but the invoice price on specialties and the invoice price on brand name drugs, it is what it is. I mean, it's what we are paying on those invoices, those rebates that are supposedly flowing into pharmacies, and I can't comment on hospitals because that's not what I'm familiar with, but those dollars just aren't there. And this is really a workaround. We have medical contracts and reimbursement contracts with maximum allowable costs set between us and the insurer. And those are negotiated and agreed upon prior to services being provided. Nothing in the bill originally stated that there couldn't be differences between in-network and out-of-network. So I don't see the concerns that are being raised there, but if one infusion center or one site is in network, you know, the patient shouldn't be penalized from choosing one in-network provider over being steered to a facility that's owned by the insurer that's 100 miles away that they've got to drive there and eat that cost. And this bill is really trying to maintain, I guess, originally patient access and providers access to being able to provide care. And with that, I guess I would stand for questions.
Questions for Mr. Meyer? Not seeing any, Matt? Thank you. Hope
Thank
it's a
you very
lovely day
much.
in Sheridan. Every day is a lovely day in Sheridan.
That's right.
Any other public comment? Yeah. Any other public comment? All right, we'll close public comment. Hey, so committee, let's have a quick talk about how this works. And I know Representative Klaus and I, we sat on a working group. We thought we got to a pretty good place, the legislation. We went back and looked at our laws and what a specialty pharmacy is and how we do specialty drug. There's just still a lot of inconsistencies, as I think you heard. And I at least would say from my perspective, everybody on this issue really has tried in good faith to get to where we're going and be agreeable. So I think we can have about an hour of amendments and discuss some of them, maybe get it to session. I think we could have another meeting in November, either a Zoom meeting, an in-person meeting for one day on this. And I was kind of thinking on prior auth, but that went a little differently than I thought it would. All right, we can put it on the agenda for next year. And so I guess what I'm asking is we're probably going to break to lunch, have some internal communication, kind of figure out where we are, see what you want to do, decide if you want to have another meeting to discuss this. I think we would have another meeting among all the interested parties in a working group before another legislative meeting, so we could come to you with some pretty strong agreements, maybe one or two policy questions and hammer it out, I think is where I would like to go. But if you want to discuss it over lunch with each other, maybe with some of the people who've been involved, see where they want to go, that's probably my ask. With that, is there anybody, and I'm still kind of in the middle of this, so I can't move on to the next topic, but let me check, is there anybody who can't wait for another hour and 15 minutes to testify from EMS? Okay, with that, it's been a long, rough morning. How about we break for lunch, and actually maybe we can come back at 1:15 or 1:20 whenever we get a quorum, and then we'll figure out a way forward here on the white bagging bill. I've talked to the governor's office. I don't believe they need an hour, and she did email, I think, us last night. Did you email the entire committee, Jen? Just me. We'll send it out to all of you on kind of what the ask is going to be on the governor's EMS task force and where we're hoping to go there, and think we can knock that out in 15 minutes and still stay on agenda for the rest of the day. So anybody have any comments before we break for lunch? Great. We'll break for lunch. I'll see you back here. Let's say 1:20. Enjoy beautiful Saratoga.
I can still see you.